So let us now discuss anxiety disorders. So all of us have experienced anxiety. So anxiety is a diffuse, unpleasant sense of apprehension or nervousness along with physiological symptoms like sweating, tachycardia, tremors, restlessness, chest pain. So along with these symptoms, it occurs. Now, anxiety, when it is excessive or it is occurring in situations where it should not occur, then that is anxiety disorders. So let's talk about the epidemiology. So as a group, it is the most common psychiatric illness in the world. We have discussed in India, most common psychiatric illness is depression. And if we talk about individual disorder, most common is specific phobia. All anxiety disorders more common in females than males, except social anxiety disorder, wherein it is seen equal in males and females. Let's talk about panic disorder. So before that, let's try to understand what is a panic attack. Panic attack is an acute, sudden onset of intense anxiety with symptoms like there is palpitation, sweating, tremors, shortness of breath, chest pain. Along with this, patient complain of fear of impending doom. So there is a feeling that everything is about to end, or there is a fear of dying, or losing control, or fear of going crazy. So this is what is a panic attack. Then what is panic disorder? Recurrent panic attacks is panic disorder. These are basically unexpected. That means they're not restricted to any particular situation. So patient may report that it occurred first time when he was at his office. Few days later, another panic attack came when he was at his home. Another attack came when he was driving. So they can occur anywhere. They're unexpected. And they usually last for few minutes. So maybe 20 to 30 minutes. Rarely they may last for more than 1 hour. And in between these attacks, the patient is normal. Some patients may also report of anticipatory anxiety. That means in anticipation of another attack, they may report of anxiety. But otherwise, usually they are normal in between these attacks. Most common comorbid condition. Comorbid means another psychiatric condition which may exist along with panic disorder is agoraphobia. So many patients of panic disorder may also have agoraphobia. Now differential diagnosis. Now because there is presence of certain physical symptoms, somatic symptoms, it must be differentiated from certain physical disorders. Like for example, myocardial infarction. Again, even in myocardial infarction, patient may report of chest pain, in angina, even mitral valve prolapse, anemia, hypertension. Then even in asthma, patient may report of breathlessness, that it is feeling of that person may be dying, pulmonary embolism. Then other disorders like seizure, migraine, hypothyroidism, endocrinal abnormalities, pheochromocytoma, hypoglycemia. So a lot of physical symptoms because occur, they should be differentiated, and these symptoms, such physical symptoms or disorders should be ruled out. Now when we talk about the treatment, in pharmacotherapy we say SSRIs are the drug of choice. So overall SSRIs, selective serotonin reuptake inhibitors, are the drug of choice. And we also have benzodiazepine for short duration. Generally short duration because in long term use benzodiazepine may also cause dependence. So as we know SSRIs would take some time. So for short duration we add benzodiazepine. Now if you are asked drug of choice for an acute attack. So if a patient with panic attack comes to you in the state of having this panic attack, what will you give? In those instances, benzodiazepine would be the drug of choice. So you may give one benzodiazepine like a clonazepam and the patient may report of improvement in the symptom. But overall, the drug of choice is SSRIs. Again, other drugs like even venlafaxine may also be used. And in psychotherapy, it is the cognitive behavior therapy which is the therapy of choice. Now, when we talk about the treatment of choice for a panic disorder, a combination of pharmacotherapy and psychotherapy, that is SSRI plus CBT, is generally a preferred treatment. So treatment of choice would be a combination. Second is agoraphobia. Now agoraphobia is when there is a fear or anxiety in two or more of the following situations. So it is very important, if someone reports of anxiety in any two or more of these situations, then we call it as agoraphobia. So these situations like public transport. So person reports of fear or anxiety in a bus, plane, metro, or in open spaces, big, huge spaces like big parks or big parking lots. Person reports of anxiety in closed spaces like lift, like in theaters when it is closed from inside, or in crowded places, or when standing in a line, person may report of anxiety, or when the person is alone out of the house, the person may report of anxiety. So if a person is having anxiety in any two or more of the situation, then we call it as agoraphobia. Please remember, if it is just one situation, then we'll not call it as agoraphobia. The concept behind this is basically the patient is having anxiety in places from where escape might be difficult. For example, if a person is in a public transport, or in a plane or in a metro or in a train, how to stop it when he develops anxiety? Or in open spaces where the person cannot find the exit, or in closed spaces like, if the lift is moving, how to get out? In crowded places, or when the person is out of the home, who will help me if attack comes? So the concept is patient is having anxiety in places where escape might be difficult. Again, most common comorbid psychiatric disorder with agoraphobia again is panic disorder. So these two conditions may coexist in one person. Now coming to the treatment again, person is having anxiety in a particular situation. So behavior therapy generally is useful, and one of the behavior therapy of choice for agoraphobia is systematic desensitization given by Joseph Wolf. So it is the therapy of choice. Okay, so please remember these along with agoraphobia, two more anxiety disorders we will discuss which are occurring in a particular situation. So panic attack would occur unexpectedly. Now these three disorders which we are discussing, here anxiety is occurring in a particular situation. Okay, again therapy is the treatment of choice here. Along with this, again to choose one between behavior therapy and CBT, behavior therapy is a preferred treatment. So CBT uses both cognitive techniques and behavior techniques, where behavior therapy uses only behavior techniques. Then along with this, we can also use drugs like pharmacotherapy, SSRIs we can use. Along with this, short-term benzodiazepines and even venlafaxine may be used. Now third is specific phobia. As the name suggests, there is a strong, persistent, irrational fear of an object or situation. So specific phobia, fear to a specific object or situation. It is irrational. That means the object or situation is not harmful, but the person is perceiving it to be harmful. So it is specific phobia. Again, many common phobias like acrophobia, wherein fear of heights, allurophobia, fear of cats, cynophobia is fear of dogs, claustrophobia is fear of closed spaces, misophobia is fear of dirt and germs, then hydrophobia is fear of water, thanatophobia, Thanos, god of death, thanatophobia is fear of death, then nyctophobia is fear of dark, xenophobia, xenograph use different species, so xenophobia is fear of strangers, pyrophobia, pyro means fire, fear of fire. So these are some of the common named phobias. Again, coming to the treatment, again it's a situational, fear or anxiety. So again, psychotherapy is the treatment of choice. So again, systematic desensitization is the therapy of choice. Now what we do in systematic desensitization, 3 steps we do. First is we teach the person relaxation techniques, and then we make a hierarchy. So from least anxiety to maximum anxiety provoking situation, we make a hierarchy. Let us say number 1, suppose a person is fearful of cats. Okay, so number 1 least anxiety may be when we ask him to imagine that there is a cat. There may be some anxiety. Number 2 may be when we tell him that there is a cat, on the same floor. Number 3 is when we say that the cat is just outside the door of his room. 4 maybe we may just open the door of the room. 5th is when the cat is inside. So this is how we make a hierarchy from least anxiety to highest anxiety provoking situation. And subsequently we move the patient from least anxiety to highest anxiety. So in number 1 step, the patient will develop anxiety. We ask him to use these relaxation techniques. The anxiety will go down. And subsequently we will make the patient move to the next step. So this is systematic, stepwise we are desensitizing the anxiety. Next is there is therapeutic graded exposure or in vivo exposure. So it is again similar to systematic desensitization, but we don't teach any relaxation technique. We make a hierarchy and we move stepwise. So basically patient learns to get habituated to the anxiety. So after some times in the first step the anxiety would decrease, and then we will move to the next step. So this is therapeutic graded exposure or exposure and response prevention. The next is flooding or implosion. Herein we expose the patient with supramaximal stimulus. So we flood the patient with the stimulus. So maybe we can just from the start only we put the patient in a room full of cats. So this is flooding. So patient experiences intense anxiety which gradually decreases. So person feels that the anxiety would gradually decrease. So this is flooding. The next is modeling or participant modeling, where the patient learns by imitation. So maybe therapist makes contact with the phobic stimuli. So maybe therapist may sit nearby and the cat may be on the lap of the therapist, and it is demonstrated to the patient, and gradually by this modeling the person may learn to control the anxiety. Then pharmacotherapy we can use SSRIs. Along with this we can give benzodiazepines. Next is social anxiety disorder or social phobia. So again here the phobia or anxiety is in social situations, including situations where that involve scrutiny with the strangers. So basically what is the actual fear? So patient has anxiety, let us say in a function like in a marriage or in a conference. But the actual anxiety is, or actual fear is fear of embarrassment in front of others. So patient, may fear that, what if I'm in a wedding and I'm eating and I spill food on my face? Or what if I blurt out something which will embarrass me in front of others? So the actual fear is fear of embarrassment. This is social anxiety disorder. Now again in the treatment, pharmacotherapy again is shown to have good effect. So SSRIs along with short-term use of benzodiazepine, even venlafaxine may be used. Beta blockers sometimes can be used like propranolol for performance anxiety. So suppose a person has to go in a meeting where they are full of people. So patient, again, this can improve the anxiety because again, it will decrease the sympathetic symptoms associated with anxiety. And in therapy, here CBT, cognitive behavior therapy, has shown to be of good results. Next is generalized anxiety disorder or GAD. So what is happening? There is excessive anxiety and excessive worries. So there is generalized and persistent anxiety, as the name suggests. It is not restricted to any particular situation. In fact, it is free-floating anxiety. This anxiety is occurring in nearly every situation. On small things, the person is having anxiety. And along with this, patient is having excessive worries. This is very important, excessive worries. So patient may, these worries may involve small, simple daily activities, timelines, health. So patient may worry that husband is late from office. Oh my God, what if something bad might have happened? Children are late from, school. What if something bad might have happened? So these small day-to-day, activities, the person will have excessive worries. So this is generalized anxiety disorder. So along with this, of course, there may be physical symptoms, palpitations, tremors, headaches. Such symptoms may also be there. Now coming to the treatment, again here the treatment pharmacotherapy is SSRIs along with the short-term benzodiazepine, venlafaxine can be used, and psychotherapy is cognitive behavior therapy for GAD. Now let's talk about obsessive compulsive and related disorders. So this is basically a term in which many disorders have been included both in DSM-5 and ICD-11. So let's talk about various disorders included under obsessive compulsive and related disorders. First is OCD, obsessive compulsive disorder. So let's understand, these are recurrent obsessions and compulsions. So you can remember the characteristics of obsession by the acronym ROSI. So R is, there are recurrent intrusive thoughts, images, impulsive. So these impulses, thoughts, they are recurrent and they are not pleasurable to the patient. So patient may have these thoughts many hours a day. So patient may report that 2 hours, 3 hours, such thoughts are occurring. Second is O. The patient knows that these are the patient's own thoughts. So they are not imposed by others, like, they are not thought insertion. This patient acknowledges that these are my own thoughts, but these are senseless. So person recognizes them as irrational. So person knows that I know these are wrong thoughts. These should not occur. Unlike delusion where the person does not understand that those are irrational thoughts. So again, this differentiated from delusion. And I is the person wants to, stop these thoughts, want to resist these thoughts. But the person is not able to resist these thoughts. They are irresistible. Patient tries to suppress them but is not successful. So this is what is ROSI. So we'll talk about various obsessions, and we'll discuss some examples. And what is compulsion? As the name suggests, these are repetitive behaviors. For example, washing or, checking, or they may also be mental acts like, person is counting in the mind. So these are repetitive. Again, patient may spend hours and hours on doing these acts. And these again, patient may perform in response to an obsession. For example, person is having repeated thought that my hands are dirty and the person starts washing the hands. Or they may be done in a very rigid, rule-bound way to reduce anxiety. They're time-consuming. Example, they may, patient may spend more than an hour every day and they cause clinical significant distress and impairment of functioning. Now, obsessions and compulsions, we use this term for them, they are ego-dystonic. So ego-dystonic means, ego means mind, dystonic means they're unacceptable. They're unacceptable to the mind and sometimes also known as ego-alien. Again, patients can have only obsessions, patients can have only compulsions, and sometimes patient can have both obsessions and compulsions, which is the most common presentation. Now, lifetime prevalence is around 2 to 3%, and the most common comorbidity with OCD is depression. Now, if we talk about the etiology, again, there is a serotonin hypothesis of OCD, that there is serotonin dysregulation. And in the treatment, we use, some of the drugs which improve this dysfunction. Then neuroanatomical model of OCD is that there is a corticostriatal thalamic cortical circuit, CSTC circuit, which goes from the prefrontal cortex to the striatum to the thalamus and back to the prefrontal cortex. So there is dysfunction in this circuit which may lead to OCD. Also, it is seen that there may be bilaterally smaller chordates in the patients with OCD. Now let's talk about the most common obsessions. So the most common obsession is obsession of contamination, wherein the person has repeated thoughts that the hands are dirty or things around are dirty. So there is contamination. Second most common is pathological doubts. So pathological doubts is when patient may have doubt. Patient knows that, these are again irrational doubts. So patient may go out of the room and, thoughts may occur, doubts may occur that whether I bolted the door or not, whether I switch off the light or not. Patient knows that the person has switched off the light, but these doubts would occur again and again. So these are pathological doubts. Then need for symmetry. Person may have thoughts that everything should be placed symmetrically. Then aggressive obsessions. Patient may have thoughts, let us say getting a thought to slap the person standing in front of them. Person would say, no, I don't want to. This is an irrational thought, but it is occurring again and again. Or it may be a sexual obsession, like, touching the opposite gender inappropriately. Again, the person would say, I don't want to do this. It's an irrational thought, but it is occurring again and again. And sometimes it can be multiple. So these are various obsessions. Let's talk about the compulsions. C for compulsions, C for checking. So the most common compulsion is checking. So when person is having pathological doubt, the person may come and may check the door or may check the light. And patient may not just do once or twice, may do, for hours and hours. So this is checking compulsion. Then washing is the second most common. So in obsession of contamination, subsequently now the person starts washing. Then others like counting. Person is, doing things in counts, multiples, or, if the person is counting something, the person is counting again and again. Then symmetry and precision. Now patient is also arranging everything in symmetry. Maybe eating and cutting every piece of the meal in equal sizes. The person is shaving and doing, very, very precisely. Then person can have even multiple compulsions. So these are some of the obsessions and compulsions. Now let's talk about the treatment. In the treatment, we have pharmacotherapy and psychotherapy. Now in the pharmacotherapy, the first line is the SSRI, selective serotonin reuptake inhibitor. Okay, and one more first line drug is clomipramine. It is the only TCA which is a first line drug for OCD. Okay, it is most serotonin selective TCA. Okay, but out of the two, so both can be used as a first line drug, but out of the two, if you have to choose, we will prefer SSRIs because of better side effect profile. So their side effect profile is better. So if you have to choose one, you can choose SSRIs. Now, along with this, they are also augmenting agent. So suppose we are giving a patient SSRI or clomipramine, but to improve the effect, we can add a drug as an adjunct or as augmenting agent. So antipsychotics such as risperidone, aripiprazole, haloperidol, olanzapine, these can be used as augmenting agent to improve the effect of the first line drugs. Now coming to the therapy, again cognitive behavior therapy is the treatment, and primarily we use the behavioral techniques such as exposure and response prevention or ERP. So basically what we do is we expose the person of the feared situation. Suppose somebody is having obsession of contamination, we put some dirt around the patient, so we expose him to the stimuli, and what will be the response? To go and wash, and we prevent that response. So ERP is a preferred therapy of choice. So if to choose between ERP and CBT, so you have to choose ERP. More specific answer would be ERP. Now, if you are asked what is the treatment of choice of OCD, so we know the drug of choice, we know the therapy of choice. The treatment of choice is the combination. So combination of pharmacotherapy and psychotherapy. So SSRIs plus ERP would be the combination, would be the treatment of choice. Now then there are certain other somatic techniques which are used for extreme cases, that are resistant. So you are giving a patient adequately, you have given medicines, you have given therapy, but it is not showing much improvement. Then we can use certain other techniques such as ECT. ECT can be used, and also psychosurgeries can be used. So there are certain surgical procedures which may help to improve OCD. So there are certain ablative procedures. We ablate certain areas of the brain, because these have shown to be implicated in the development of OCD. So like subcaudate tracheotomy or anterior cingulotomy or anterior capsulotomy or gamma knife capsulotomy. So such psychosurgical procedures may be used in the treatment of OCD. Now, second disorder under obsessive compulsive and related disorders is body dysmorphic disorder. So as the name suggests, body dysmorphic disorder, there is something dysmorphic in the appearance. So this is abnormal morphic morphology. So patient is preoccupied with perceived defects or flaws in the body, in the physical appearance. So patient may have no concern that my nose is large or nose is small, ears are large, ear is small. So such type of concerns patient may have, although they are absolutely normal, there may be just mild, abnormality may be there, but the person is preoccupied. Then next is hoarding disorder. Hoarding is to collect. So acquiring things and, difficulty in discarding things of little value or no value. So person is collecting things and it leads to cluttering, leading to significant distress or impairment of functioning. So there is no space. Patient may have to compromise on so many other things because he's not ready to discard those items. Then, again, it is driven by the fear that, losing these things which are important, or, there may be a distorted emotional attachment to these things. So patient may have, is driven by such thoughts or fears. Now, something about the treatment is, hoarding disorder is difficult to treat. And, psychotherapy, usually we use cognitive behavioral therapies out of all the therapies more effective, but again, it is difficult to treat. So out of even, if you're asked which of the following disorders, CBT may have shown to have less effect, let us say the options are washing, checking, symmetry or hoarding. So the answer would be hoarding. Then fourth is trichotillomania or hair pulling disorder. So here, as the name suggests, there is recurrent pulling of one's hair and which is resulting in hair loss. So patient there is an intense anxiety, and after, till the time the person does not pull the hair, the anxiety does not decrease. So this is occurring in hair pulling disorder leading to alopecia. And it is accompanied by unsuccessful attempts to decrease or stop the behavior. Now hair pulling sometimes, so usually the person will pull the hair, most commonly from the scalp, but it can involve any part of the body. The person will just pull the hair and may throw. But some patient, after, plucking the hair, they may, swallow the hair. So there may be trichophagia. Okay. And if trichophagia occur, then complications like trichobezoil may be there, malnutrition and even intestinal obstruction. So suppose, in the question, the person, a surgeon takes out a trichobezoil from the stomach, where will you refer this patient? Now, this patient may be having trichotillomania, so you should refer to the psychiatrist. Then last is excoriation or skin picking disorder. So as the name suggests, there is recurrent picking of the, one's own skin. So now the person is repeatedly picking the skin, which is resulting in skin lesion. Again, such patients should be referred to a psychiatrist, not a dermatologist. Again, which is accompanied by unsuccessful attempts to decrease or stop the behavior. The most common area is usually the face, but hands or other areas of the body may also be involved. Now, ICD-11 also has introduced a similar term like DSM-5, obsessive compulsive or related disorder. Some changes you can remember. Herein, they've added this term body focused repetitive behavior disorder. In this, they have included trichotillomania and excoriation disorder. One entity which they've added here is olfactory reference syndrome. What is this? Patient has belief or preoccupation that the patient is emitting some foul smell. So it's a belief or a preoccupation again. Patient cannot smell, but patient, believes that there is a foul smell coming from his body. Then hypochondriasis we will discuss. Hypochondriasis is wherein the person is preoccupied of having a serious illness. So these are included under ICD-11. Now let's talk about trauma and stressor related disorder. As the name suggests, these disorders would occur only after a trauma or a stressful situation. Otherwise, they would not occur. If there is no trauma or stress, these disorders would not occur. Now, trauma or stressor can be a major life-threatening stressor. Like someone is exposed to war, or there is a physical assault, or someone was kidnapped or tortured. There is sexual violence, or there was rape, or there was a natural disaster like a tsunami or an earthquake. So these are some major disorders, like person may have a serious accident. So these are major life-threatening events, which if it occurs to any of us, most of us will be overwhelmed by such stressors. So if such stressors occur, what kind of disorders may occur? So person may experience acute stress disorder if the symptoms last for less than 1 month. And if the symptoms last for more than 1 month, it is PTSD. Symptoms are similar in both. The difference is how long the symptoms remain. Acute, as the name suggests, the symptoms last for less than 1 month, and PTSD symptoms last for more than 1 month. So let us understand what is PTSD. Post-traumatic, as the name suggests, it's a stress disorder after trauma. So exposure to again a major life-threatening event and duration for more than 1 month. So let us remember the symptoms with the mnemonic Mahi. So Mahi is a nickname of Mahendra Singh Dhoni. Let us remember with this the symptoms. So let us say a person had an accident, serious accident. He was admitted in the hospital, after which he was discharged, and he has developed some symptoms. So M is mood and cognitive symptoms. So person may develop negative emotional state like fear, anger, sadness, or may even have negative beliefs like, I am a bad person or I am a very bad driver, although person was a very good driver, but person may develop such mood and cognitive symptoms. Then A is avoidance. Again, very important. So avoidance is person may avoid feelings, memories or thoughts related to the event. So someone comes and talks about that event, the person does not want to talk. Or he may start avoiding people, places or objects which remind him of the trauma. For example, let us say he was driving with his friend. So friend comes and meet him, he does not want to meet him. The car comes from the mechanic and repaired, but he says, I don't want to see this car anymore. So the person is avoiding things which are related to the trauma. Then H is hyperarousal. So person may be in a hyperarousal state. There may be irritability, hypervigilance, insomnia, or there is decreased concentration. And last I is intrusion symptoms. So these are re-experiencing symptoms. So patient may have distressing dreams about that event, memories may occur, and very interesting flashbacks. So patient may report that person is sitting and suddenly the entire event come like a flashback. So these symptoms are present. Again, very important, especially for exam. You see symptoms like intrusion symptoms, avoidance symptoms. Again, think of PTSD. Coming to the treatment again, psychotherapy is the treatment of choice and the therapy of choice is CBT. And again, one more therapy which can be used is EMDR, which is eye movement desensitization and reprocessing therapy. So what we do is we ask the person to remember that event, recall that event, and we are giving some stimulation, some photo stimulation to the person. So this is EMDR. Again, it is shown to improve the symptoms in PTSD. But therapy of choice is CBT. Then we can also use drugs like SSRIs. Now let's talk about dissociative disorders, conversion disorders, and somatic symptoms and related disorders. Now basically what is common among these disorders is that the symptoms, they don't have any bodily cause. So symptoms would appear to have some bodily cause, but there is no bodily cause. So in such patients, they come with various symptoms, and if you examine the patient, everything comes to be normal. And if you investigate these patients, again, is normal. And many times in the question, a stressor may be given, may or may not be given. So person having certain complaints, but everything seems to be normal. So you may think of these disorders. So let us try to understand these disorders one by one. First is dissociative disorders. Now, dissociative disorder, there is a disturbance in one or more mental functions, such as memory or identity or perception, consciousness or motor behavior. So one function is dissociated from the rest of the functions. Again, there is no bodily cause. Basically, the symptoms are created by the mind. Okay. Now, first is, let us discuss some of these disorders. Dissociative amnesia. So as the name suggests, there is amnesia or loss of memory. So inability to recall certain important personal information which are usually traumatic in nature. But please remember, this amnesia is not organic. Okay, like amnesia seen in dementia or amnestic disorder, there is a cause, there is a bodily cause, but here there is no such cause. And generally these are inconsistent with the normal forgetfulness. For example, a person is rescued 2 days after he was kidnapped and tortured. And the police family members ask him what was done to him, where was he in the last 2 days. He does not remember anything. He remembers everything 2 days before and everything after, but he does not remember those 2 days of trauma. So again, what is happening is this amnesia is not caused by any body dysfunction. This is caused by, again, maybe stress. Because of so much stress, the person's memory is dissociated from the other functions. So this is dissociative amnesia. Then depersonalization, derealization disorder. So what is depersonalization? As the name suggests, there is a feeling of detachment from the self, personalization. So patient, feels as if, his self is unreal. He patient report, as if he's watching himself in a movie. Feels detached from the self. This is depersonalization. Then derealization, as the name suggests, there is a feeling of detachment from the world. So person feels that as if the world is unreal. Everything around is unreal. But again, in these disorders, the reality testing is intact. Again, these are neurotic type of disorders. So reality testing is not impaired. Okay. They know what is real, what is unreal. This is just a feeling of, that things are unreal or things of detachment from the self. Then dissociative identity disorder or multiple personality disorder. So as the name suggests, there are two or more distinct personalities which exist in an individual. So all of us have one personality, but these patients have two or more personalities, and only one personality is evident at a time. And one personality may not be aware of the other personality. So patient may have 2, 3 or even more personalities in one individual. So a person is working in an office and he's scolded by everyone, even his junior would scold him. But he's, walking on the street and someone says something to him and he starts fighting with them. So there are two types of personalities. So one in the office, one when, he's working, and both these personalities are unaware of each other. This is dissociative identity disorder. And next is conversion disorder. So in ICD-11, it's put it under dissociative disorder, dissociative neurological symptom disorder, while in DSM-5 they have put it under somatic symptom disorder. The name is functional neurological symptom disorder, a very apt name. So as the name suggests, the patient has certain neurological symptoms, but these are functional in nature. That means there is no bodily cause. So neurological symptoms these symptoms don't have any bodily cause. Now these symptoms can be sensory symptoms. So patient may complain of paresthesia, anesthesia, or the person may say that I cannot hear anything, or the person just says that I cannot see anything, So a 7-year-old girl is listening to her parents fighting and they're, planning to take a divorce. Mother comes and the girl says, "Mother, I cannot see anything." So, she was taken to an emergency, doctor was called, everything, examination, investigation, everything was normal. And gradually therapy was started and the girl started seeing things. So this is, classical example of conversion disorder. There is no bodily cause. Then these symptoms can be motor, like abnormal movements. Patient may report of paralysis or there is paralysis. Person is not able to move the body or weakness is there, although there is no bodily cause. There may be pseudo seizures. So seizure-like activity may be seen, but these are not true seizures. So they can be sensory, motor, or both symptoms can be seen in the patient. Now there is interesting phenomenon known as labella indifference. So patient, in these patient is having some serious symptoms, like this girl, who is reporting of not able to see. But patients have inappropriately careless attitude towards these serious symptoms. So, if any of us is not able to see for a few seconds, will be, very, very terrified. But these patients will be, sitting comfortably as if they are indifferent to these serious symptoms. So this is labella indifference. Next is somatic symptom and related disorders. Previously, these were known as somatoform disorders. So first is somatic symptom disorder, which was previously known as somatization disorder. ICD-11 classifies it under bodily distress disorder. As the name suggests, patient is having somatic symptom, bodily symptoms. So preoccupied with somatic symptoms. There is pain in my abdomen, there is pain in my leg, there is bloating sensation, feelings of nausea. Such type of somatic complaints are there. Again, you investigate, nothing comes out. Okay, so still, even after reassurance, the person is preoccupied with these symptoms. So this is somatic symptom disorder. Next is illness anxiety disorder. So illness anxiety disorder is a new term. It was, known as hypochondriasis. Even now in ICD-11, it is known as hypochondriasis. So as the name suggests, illness anxiety disorder, anxiety of having some serious illness. So patient is preoccupied that I am having some serious illness. The person may name that illness. So patient may say, no, I think I am having a brain tumor, or I think I am having tuberculosis. Investigations, everything is done, nothing has come out, but person is preoccupied. Person may have certain symptoms, but there is predominant preoccupation of having a serious illness. So this is illness anxiety disorder. Now, in all these disorders, dissociative, in conversion here, even in somatoform, again, the treatment usually is the therapy. Now, then, those all were symptoms were unconscious symptoms. Those symptoms were unintentional. Patient was not aware that he is having these symptoms. Okay, it was produced by the unconscious mind. But sometimes there may be deliberate falsification of symptoms. patient consciously or intentionally, falsify that he's having some problem. The aim or the goal may be to receive medical attention or to assume a sick role. Person wants medical attention, that doctors, nursing staff pay more attention to him. Okay, or it may be to receive certain external gains, external benefits like monetary or other benefits. So it can be of two. So if the goal is to receive medical attention, it is factitious disorder, which is a psychiatric diagnosis. It needs to be treated. While if the main aim or objective is external gains or benefits, then it is malingering, and malingering is not a psychiatric diagnosis. Okay, so let us talk about factitious disorder, also known as Munchausen syndrome. So what happens is patient produces fake symptoms. It can be physical symptoms or it can be psychological symptoms, and the aim is to assume a sick role and to gain medical attention. This person wants, so in the history you may get, there was history of repetitive admissions, patient is insisting on admission, everything is normal or does not require, but patient may insist that please admit me. So this is factitious disorder. Then there is something known as factitious disorder by proxy or Munchausen by proxy. Here the person, usually a caretaker, produces symptoms in another person, but the aim is again to gain medical attention. So for example, a mother says that induces symptoms on the baby, on her infant, that he is not feeding properly, he is having crying spells, although there are no such symptoms, but the mother would insist on these symptoms to gain medical attention. So let us discuss substance use and addictive disorders. So let's talk about substance use disorders. So in ICD-11, the term is described as dependence. So what is dependence? In dependence, there is a strong desire or a sense of compulsion to take a substance, which is known as craving. So a person who has substance dependence would report of craving. Then there is also, symptoms like withdrawal symptoms and tolerance is seen. Both of them indicate that there is development of now physical dependence. So withdrawal symptoms are basically symptoms which appear when the person stops or significantly reduces the amount of substance. These symptoms may be physical symptoms. For example, with alcohol, there may be tremors, or there may be psychological symptoms. Tolerance is basically when higher amount of the substance would be required to produce the same effects. So now the body is tolerating the lower amount and more amount is required now. So again, withdrawal symptoms and tolerance is indicative of physical dependence. Then there is difficulty in controlling substance taking behavior. Person cannot stop the onset of or termination of substance use. There is progressive neglect of alternate pleasurable activities or interest because of substance. So person is neglecting other activities which he would do before, but now he is spending more time in taking the substance. And there is persistence of substance use despite knowing the evidence that it may cause harmful consequences. So person consuming alcohol may know that it is affecting his liver, but still there is persistent use. So these are the symptoms seen in dependence. DSM-5 uses the diagnosis of substance use disorder. So again, symptoms are similar. Let's talk about the first substance, which is alcohol. So what is there in beverage alcohol? It is ethyl alcohol or ethanol. Now alcohol is a CNS depressant. So chemically it's a depressant. The legal limit of driving in India, is there should be 30 milligram. More than that is not allowed. So 30 milligram per deciliter. Now alcoholic blackouts can occur when the blood alcohol concentration is 200 to 300 milligram per deciliter. So alcoholic blackouts are basically episodes of amnesia. Usually they are anterograde amnesia episodes seen during alcohol intoxication. When the amount of alcohol is so much in the blood, it may lead to amnesia. So patient may not be able to remember things which he did after consumption of alcohol. So it's in a anterograde manner. So anterograde amnesia may be seen. Now let's talk about alcohol withdrawal. So let us say a person is consuming alcohol. Okay, let us say he is consuming 1 bottle of alcohol, 750 ml of alcohol every day, and suddenly he stops taking alcohol or significantly reduces the amount. So the body will have some withdrawal symptoms. So let us understand these withdrawal symptoms. So these may occur after stopping the substance. So 6 to 8 hours after stopping alcohol, the symptoms of tremulousness or tremors may occur, which are classical withdrawal symptoms of alcohol, and these are the most common signs. Coarse tremors may occur. Also, along with this, other symptoms like nausea, vomiting, autonomic hyperactivity symptoms like anxiety or arousal, sweating, mydriasis, tachycardia, hypertension, these symptoms may also occur. So within 6 to 8 hours of stopping alcohol, these symptoms would occur. Now, if this withdrawal state continues 6 to 12 hours, in 8 to 12 hours, alcoholic hallucinosis may occur. So here patient may develop hallucinations. Auditory hallucinations are more commonly seen than visual hallucination, and these occur in clear consciousness. The consciousness of the person is not impaired. Now, if this withdrawal state continues, so in the next 12 to 24 hours, patient may develop seizures, alcohol withdrawal seizures. These are generalized tonic-clonic seizures, and these may also may be termed as rum fits. Okay, fits because of withdrawal of rum or alcohol, so rum fits. These may also occur in clusters. So in a span of 2 to 3 hours, multiple seizure episodes may occur. So these are also known as cluster seizures. If this withdrawal state continues, within 72 hours, patient may develop, which is a very major life-threatening withdrawal symptom, that is delirium tremens. So delirium tremens, as the name suggests, there is a state of delirium. So there is disturbance of consciousness. So there is impaired consciousness. Patient may appear disorientation may be seen, and here also hallucinations may be seen. But here the hallucinations more common will be visual hallucination. So difference between alcoholic hallucinosis and delirium tremens. So hallucinations in alcoholic hallucinosis, auditory are more common, while in delirium tremens, visual. And also very important is in alcoholic hallucinosis, consciousness is intact, it is not impaired. While in delirium tremens, the consciousness is impaired. It is a most severe form of withdrawal symptom. It's a medical emergency. If untreated, there is mortality rate is 20%. So again, it's a medical emergency. Now also, alcohol use can also lead to certain neurocognitive disorders. So two important alcohol-induced neurocognitive disorders are Wernicke's encephalopathy and Korsakoff syndrome. So person is consuming alcohol and subsequently he may develop these neurocognitive disorders. So Wernicke's encephalopathy, its onset is acute in onset, okay, and the symptoms you can remember with the acronym GOA. So G is global confusion, the person is appearing confused even. So again, even in delirium tremens, the person is confused how to differentiate. First of all, delirium tremens is in the withdrawal state, while Wernicke's encephalopathy is not in a withdrawal state. There other withdrawal symptoms are seen, while here other symptoms of Wernicke's encephalopathy will be seen. So second symptom is ophthalmoplegia. So here again there may be nystagmus, there may be horizontal gaze may be there. Sixth cranial nerve is more affected, and second most common is third cranial nerve. So the patient may come with the eyes are deviated to one side, he is not able to move the eyes, so ophthalmoplegia may be seen. Then also there may be symptoms of fall. So person is having ataxia. So these are the triad of Wernicke's encephalopathy. Now Wernicke's encephalopathy as well as Korsakoff syndrome, they occur because of thiamine or vitamin B1 deficiency. So why in a patient of alcohol use this deficiency is occurring? It may be because of multiple factors like poor nutrition or poor absorption, and basically there are neuropathological lesions which are symmetrically involved in areas, especially mammillary bodies. Other areas like thalamus, hypothalamus and other areas may also be involved, but mammillary bodies are again very important. So this is again seen in both Wernicke's and Korsakoff. Now treatment is, it responds readily to parenteral thiamine, and of course then we can shift to oral also, and generally the symptoms are reversible. Coming to Korsakoff syndrome, it is a chronic sequelae, so it occurs slowly, and the symptoms are, there is impairment in memory. So there is impairment in memory, especially recent memory. So both anterograde amnesia and retrograde amnesia is seen. Anterograde is more seen than retrograde. So inability to form new memories, that is anterograde amnesia, is more common than retrograde, that is inability to remember old memories. Also confabulation may be seen. So basically what is confabulation? Making false stories to fill the memory gaps. So person does not remember what he did last night, and when someone asks where were you, the person makes and fills those memory gaps with false stories. He's not doing intentionally, he also believes that he did what he is saying. So this is confabulation. Now again, treatment is deficiency of vitamin B1 is the cause, so treatment is thiamine. So again, it may be given for even months, like 3 to 12 months, and still some of the symptoms may be irreversible. So only 20% of the patient basically recover. So only 20% of the patient recover. Evaluation of alcohol use disorder. So screening test known as CAGE questionnaire is there. So CAGE, so C stands for, we ask the patient whether there was a need to cut down on drinking, does he thinks, or A is whether he's annoyed when asked about his drinking. G is feeling of guilt about your drinking, and E is whether you use alcohol as an eye opener to wake up in the morning. So if out of these 4, if there is a positive response of 2 or more, it is suggestive of alcohol use disorder. Other screening tests like audit, alcohol use disorder identification test, and MAST, which is Michigan Alcoholism Screening Test. Then other tests like SADQ, Severity of Alcohol Dependence Questionnaire, it basically assesses the severity of dependence. Now let's talk about the treatment. So this person who is, come in withdrawal state, so we'll treat in 2 phases. One is detoxification and the other is maintenance. So in the detoxification phase, we're going to manage the withdrawal symptoms. So usual treatment duration is around 7 to 14 days. So treatment of choice or the drug of choice in managing the withdrawal symptoms is benzodiazepines. So for all the types of withdrawal symptoms in alcohol, the treatment is benzodiazepine, and along with benzodiazepine, we'll also add thiamine, because again, many of these patients may also have deficiency of thiamine. Now, coming to benzodiazepines, so we have short-acting benzodiazepines like lorazepam and long-acting drugs like chlordiazepoxide, diazepam. So these are some of the drugs which are very commonly used in treatment of the withdrawal symptoms. So if a patient is having alcohol withdrawal, hallucinosis or seizures or delirium tremens, again, for all these, the drug of choice is benzodiazepine. So someone is having hallucination does not mean we'll start antipsychotic. So drug of choice will be benzodiazepine. Similarly, if a patient is having seizures or delirium, the drug of choice would be benzodiazepine. And so we start with high dose. So dose which will take care of the withdrawal symptoms on day 1, and gradually we taper and stop. So every day we reduce by 20%. Now treatment of withdrawal in liver disease. So many times, so patient is consuming alcohol for a long duration may also develop some liver disease. There may be deranged LFTs. So which drug to prefer? So again, some drugs undergo only glucuronidation and subsequently lead to no active metabolite, while other drugs metabolize in liver through oxidation, glucuronidation, and also lead to certain active metabolites. So drugs like lorazepam, oxazepam, they undergo glucuronidation and they don't lead to any active metabolite. So less pressure on the liver. So if liver is compromised, so we use these drugs like lorazepam and oxazepam. You can remember it with a mnemonic liver OK. So liver OK drugs are lorazepam and oxazepam. Whereas drugs like chlordiazepoxide, diazepam, usually we would avoid in liver diseases or when the LFTs are deranged. So we have taken care of the withdrawal symptoms. So now by 7 to 14 days, the person is now recovered from the withdrawal symptoms. Now we will start the maintenance phase. So it is basically to maintain the abstinence or to prevent the relapse. So first pharmacological agent is, deterrent agent or aversive agent, that is disulfiram. What is the mechanism of action of disulfiram? It's an irreversible inhibitor of aldehyde dehydrogenase, ALDH. So let us try to understand what it does. So this is the metabolism of alcohol in the body. So ethanol is converted to acetaldehyde by alcohol dehydrogenase, which is further converted to acetaldehyde, which is converted to acetic acid by aldehyde dehydrogenase, and subsequently to carbon dioxide and water. So this disulfiram is basically inhibiting this enzyme aldehyde dehydrogenase. Now suppose a person consumes, so person is taking disulfiram and he now consumes alcohol. So the alcohol will be converted to acetaldehyde, but since this enzyme is inhibited, it will lead to increase in the levels of acetaldehyde in the body, which is causing unpleasant symptoms. It is toxic for the body. It produces certain unpleasant symptoms like nausea, vomiting, there is burning sensation in face, stomach, and rarely in severe cases, it may also lead to myocardial infarction or respiratory depression in severe reactions. So what is happening is whenever the person consumes alcohol, the body is showing these unpleasant symptoms. So what he learns is whenever I am consuming alcohol, it is leading to unpleasant symptoms. So this is deterring or aversing the patient from alcohol. So this is one method. Now, then second is use of anti-craving drugs, or anti-craving agents. So craving is again one important factor because of which the patient may again lead to start of consuming alcohol. So we use certain anti-craving agents like acamprosate. Acamprosate is a NMDA antagonist, which is a glutamate receptor. It is shown to have anti-craving properties. Another one is naltrexone, which is a opioid antagonist. Again, it has anti-craving properties. Now, then there are other anti-craving agents. Both acamprosate and naltrexone, they are FDA approved. The others which we are discussing, they are not FDA approved. So you can remember it with a mnemonic that you will tell the patient alcohol is not best friend. So alcohol is not your best friend. We will learn some anti-craving agents. So A is acamprosate, N is naltrexone, O is ondansetron, which is a 5-HT3 antagonist, T is topiramate, which is an anti-epileptic agent, B is baclofen, which is a GABA B agonist, and F is fluoxetine, which is a SSRI. So these are some of the list of anti-craving agents. The approved ones is the first two. Now then there are certain non-pharmacological treatment methods like cognitive behavior therapy. Then AA or Alcohol Anonymous groups are there. These are self-help groups which follow 12-step based approach to stop alcohol. Let's talk about the second substance, which is opioids. The opioids are derived from opium poppy plant, that is Papaver somnifera. Now heroin is the most commonly abused opioid. It is diacetyl morphine. There are various street names of heroin like smack, brown sugar. These basically also carry certain impurities like chalk powder, quinine. Okay, so they have certain impurities. What are the symptoms of opioid intoxication? So someone has consumed large amount of opioid, so leads to intoxication. So a triad of symptoms can be seen: respiratory depression. If you look into the eyes of the patient, what will you find? You will find pinpoint pupil or meiosis and coma. So these are clinical triad of opioid intoxication. And what is the treatment? The drug of choice for opioid intoxication is, we will use IV naloxone, which is an opioid antagonist. It is a short-acting drug which we use to treat the intoxication. Let's talk about opioid withdrawal. So someone is consuming opioid and suddenly stops consuming opioid. Again, very interesting symptoms which may be seen in the withdrawal state. These are basically flu-like symptoms. So let us try to club these symptoms together so that it becomes easy for us to understand and remember. So first you can remember that there is pain. So patient may report of muscle cramps, bone aches, abdominal cramps, So there is, a lot of pain in the body. So after stopping the substance opioid, the patient may report of pain. Second is, you can remember, there is leaking from the body outlets. So the person may report of diarrhea, there is lacrimation, there is tears, then rhinorrhea, there is runny nose, sweating, even the sweat glands are leaking. So there is leakage of body outlets. Then patient reports of piloerection or goose flesh. So there is erection of the hair on the body. Then a lot of yawning. Patient may have excessive yawning in the withdrawal state. And now if you look into the eyes of the patient, in intoxication there was meiosis. In withdrawal there is pupillary dilation or there is mydriasis. Along with this, other symptoms like the temperature may increase or decrease. Then again the autonomic symptoms may fluctuate. These may be other symptoms. Insomnia, these things may also be seen. So these are some of the important symptoms seen in the withdrawal of opioids. Now let's talk about the treatment of opioid. So again, we'll treat it into two phases. One is the detoxification and the other is maintenance. We'll manage the withdrawal symptoms in detoxification. Now in detoxification, the person is devoid of opioids. So what we'll do? So person was consuming maybe impure forms. So what we'll do is we will replace it with opioids. So first drug which we can start with is methadone, which is a opioid agonist. Another drug which can be used is buprenorphine. Please remember like this: buprenorphine, morphine, norphine. So again, it's a opioid. It's a partial opioid agonist. So we can give these drugs. Again, we will start with some high dose and then gradually we'll taper and stop. So we'll take care of the withdrawal. Usually by 2 to 3 weeks, the withdrawal symptoms are taken care. Then there is another method that rather than starting any opioid, we can also do symptomatic treatment. So whatever withdrawal symptoms are there, we can treat those symptoms. So one of the drug which is used is clonidine. So clonidine is a alpha-2 agonist. It works at the presynaptic level. It decreases the sympathetic symptoms. So a lot of sympathetic hyperactivity seen in withdrawal state. So symptoms like sweating, restlessness, tremors, rhinorrhea, those symptoms are taken care. And rest for other symptoms, for example, if there is pain, we can use certain painkillers like non-steroidal anti-inflammatory drug. If there is insomnia, we can give benzodiazepines. So such symptomatic management may also be done. So once we have treated the withdrawal symptoms, now we'll come to the maintenance. So basically to maintain abstinence and to prevent relapse. So again, in this first strategy which we use is opioid substitution therapy. So what is happening? Patient is using impure forms of opioid, and many times patient is also injecting, which may lead to spread of infections like HIV, hepatitis. So this approach is harm reduction approach. So what we do is we substitute those impure forms with pure forms. So we ask the patient to come to us every day, and daily we give him a pure opioid so that he does not use those impure forms. So this is opioid substitution therapy, OST. So again, herein, as we said, that we will replace the medically unsafe with the safe agonist. So drugs which we use, again, methadone, buprenorphine are the drugs which we used. Now, another strategy is opioid antagonist treatment. So again, we can use naltrexone. Here we will use naltrexone because it blocks opioid receptors. So we give the patient, so the naltrexone will block the opioid receptor in the body. And now if the person will use opioid from outside, the person will not, produce or get any euphoric effect. So patient will stop using opioid because it is not giving any euphoric effect. So this is another strategy which we can use in maintenance. Then there are certain non-pharmacological treatment methods like cognitive behavior therapy, and similarly, just like AA groups, there are narcotic anonymous groups again which follow 12 steps. These are self-help groups. Now let's talk about the next substance, which is cannabis. Now cannabis is derived from hemp plant known as Cannabis sativa. Coming to the most common substance. Now in India, if we talk about most common substance is tobacco followed by alcohol. While if we talk about the world, alcohol is the most common substance followed by tobacco. Now in both these, please remember, if caffeine is there in the option, now caffeine would be the better answer in both. So most common would be caffeine. If caffeine is not there, then in India it is tobacco, and in world it is alcohol. Now, so but these are licit substances. These are legal substances. Most of the places they are available as legal, in legal ways. Then if you're asked which is the most common illicit or illegal substance, both India as well as the world, it is cannabis. So cannabis is the most common illicit or illegal substance, India and the world. So cannabis has various forms like ganja, bhang, hash, charas, also known with various street names like marijuana, grass, pot, weed. These are various forms. What is the psychoactive ingredient which is responsible for the psychoactive effects? It is delta 9 tetrahydrocannabinol or delta 9 THC. It leads to the psychoactive effects of cannabis. Now, cannabis intoxication gives a feeling of euphoria, and there may be a sense of time distortion. People report of slowing of time. If you look in the eyes, there is redness of conjunctiva, and many times, people who consumed cannabis, they would come and there is increase in appetite. Again, these are important symptoms which may tell us that there is cannabis intoxication. There may be hallucinations, and in excessive dose, the person may also land into delirium. There may be impairment of consciousness. Now, various phenomena associated with cannabis use. One is bad trip. As the name suggests, sometimes after cannabis use, patient experience unpleasant symptoms such as restlessness, fearfulness, panic symptoms. So this is known as bad trip. Then cannabis withdrawal. So again, cannabis withdrawal can lead to symptoms like irritability, anxiety. Please remember, intoxication was causing euphoria. So withdrawal is causing depressed mood. Sleep disturbance are there. There is decreased appetite. There was increase in the intoxication, decrease. So please remember, even, physical symptoms, withdrawal symptoms are also seen. Earlier it was believed that physical symptoms are not seen, but they are seen, although they are mild. For example, tremors, sweating, fever. There may be abdominal pain, chills. So physical symptoms are associated with withdrawal. Cannabis-induced psychotic symptom known as hemp insanity can also occur when patient develops psychotic symptoms like delusions and hallucinations. Usually it is seen these induced psychotic disorders would generally go away, or they would stop after it. If the person stops consuming cannabis, within a month, these symptoms will resolve. Okay, and if required, we may have to give low doses of antipsychotics. Then flashback phenomena may be seen. What is flashback? It is basically re-experiencing symptoms of cannabis use days or after, or weeks after the person has last used cannabis. Suppose few weeks back patient consumed cannabis and there was symptoms of euphoria and there was symptoms of slowing of time. Now, currently the person is not using, but those symptoms which the patient has experienced in the past, they come as flashbacks, or they come as re-experiencing symptoms. This is known as flashback phenomena. Amotivational syndrome again may be associated with cannabis use. As the name suggests, amotivation. Person's unwillingness to persist in any task, such as task at school or work. Again, person becomes very apathetic, lethargic, and even may gain weight. So person seems to be, highly less motivated to do things. This is amotivational syndrome. Then running amok may be seen. It is characterized by development of rage after cannabis use, in which the person may even hurt or may even kill others. So this is running amok, which may be seen with cannabis use. So in the treatment, as the symptoms, withdrawal symptoms are mild, supportive care is required, and if required symptomatic, maybe short-term use of benzodiazepines may be used. Now let us talk about the next set of substance, that is hallucinogens. Now some of the hallucinogens include phencyclidine or PCP, also known as angel dust. Again, please remember such names. Ketamine, then LSD, lysergic acid diethylamide, then mescaline, which is derived from cactus, then psilocybin, which is derived from mushrooms, even MDMA, methylene dioxymethamphetamine, also known as ecstasy. These are some of the hallucinogens. Again, they produce hallucination-like symptoms in the patient. Now, they may also cause synesthesia. Now, what is synesthesia? It is like reflex hallucination. Again, sensation in one sensory modality cause sensation in another modality. Example, the person may experience seeing of music. So we usually hear music, person is seeing music, or person may report of touching lights. Again, may be seen with substances like LSD. Even flashbacks, as we had discussed with cannabis, even that can occur, like such as, patient may have flashbacks of flashes of color or visual distortions, halos, macroscopia or microscopia, things may appear large or small. So again, these symptoms may be associated, especially with substance like LSD. So especially with LSD, they may be associated. Now, withdrawal symptom, usually the hallucinogens, they lack withdrawal symptoms, and subsequently usually they lack the physical dependence. Stimulants. Now, two important stimulants. One is cocaine and amphetamine. Now, cocaine is derived from plant Erythroxylon coca. It is derived from the leaves of this plant, and the most common method of use is basically snorting through the nose. So snorting is the most common method, and again, it is a sympathetomimetic substance. So it can lead to vasoconstriction, can cause rhinorrhea, nosebleeds, and eventually can cause nasal septal perforation. Also, long-term use can also cause jet black pigmentation of the tongue. Now, combination of cocaine and heroin sometimes is used, and this is known as speedball. So speedball is nothing but a combination of cocaine and heroin, which is an opioid. Now, adverse effects of cocaine. Now, cocaine basically, it prevents the reuptake of dopamine, so it increases dopamine, as well as it also prevents the reuptake of serotonin and norepinephrine. So it is a potent sympathetomimetic drug, like amphetamine. So it causes vasoconstriction, can cause hypertension, and also can cause damage to end organs like brain, kidneys, intestine, and also it can cause constriction in the coronary blood vessels. Also, there is increase in the load of the heart, so gradually it can eventually lead to myocardial infarction. Now, cocaine intoxication can cause euphoria, pupillary dilation. Again, it's sympathetomimetic, so tachycardia, hypertension. So such sweating symptoms can be seen, cardiac arrhythmias, even seizures can also be seen with cocaine intoxication. Auditory hallucinations, paranoid ideations. Now, tactile hallucinations can also occur. We discussed in the basics, known as cocaine bugs. So you may find scratch marks on the skin of the patient. Then cocaine causes again strong psychological dependence. There is strong craving, but physiological dependence is less, like tolerance, withdrawal symptoms are usually relatively mild. Cocaine-induced psychotic disorders, again, hallmark is paranoid delusions, delusion of persecution, auditory hallucinations. So classically, symptoms of schizophrenia may be seen, and of course, other hallucination like tactile, visual, they may also be seen. Treatment withdrawal symptoms are usually mild, and no pharmacological agents are required because the intensity of the withdrawal symptoms is again mild. Now, next is tobacco. The most common substance use disorder in India, as we discussed, and active ingredient in tobacco which causes addiction is nicotine. Now again, tobacco withdrawal, person who is consuming tobacco, again it can be consumed in the form of smoking like BD, cigarettes. It can be chewed like gutka. So again, tobacco withdrawal can cause intense craving, irritability, anxiety. there can be difficulty in concentrating, insomnia, bradycardia, and appetite may increase and lead to weight gain. Now coming to the treatment, again, treatment is, one is nicotine replacement therapy or NRT. So patient is consuming smoke or is smoking cigarette, let us say. So nicotine is the substance which is causing addiction, while person is also smoking other substances which are also carcinogenic. As we know, again, tobacco can cause, smoking or chewing can cause cancer. So what we do is we replace, all those substances, to pure nicotine. So nicotine replacement therapy. It is used to treat the withdrawal symptoms. Again, various forms of NRT available are gums, lozenges, patches, then nasal spray and inhalers. These are various forms which are available. E-cigarettes were also introduced, but now they've been withdrawn. At least from India, they've been withdrawn because it is seen that these are also carcinogenic. So these are the 5 NRTs which are available. Then non-nicotine medications can also be used. First is varenicline. Now varenicline is a partial agonist at alpha 4 beta 2. Please remember 4 is first, then 2. In alpha 4 beta 2 nicotinic acetylcholine receptors. So basically it reduces the reinforcing effect of nicotine and also relieves craving and withdrawal. And out of all the pharmacological agents, varenicline is the most efficacious. So varenicline is the most efficacious. Now it may have some serious adverse effects like neuropsychiatric adverse effects such as suicidal ideations. Now recent researches have found that they may not worsen suicidal ideation, but still these again side effects should be made known to the patient, and also they can also cause cardiovascular adverse effect, especially in patients who have a cardiovascular disease. So one should be careful. Then second drug is bupropion. Now bupropion, it is an antidepressant, it's an NDRI, we've discussed in depression. So it's an antidepressant used for smoking cessation. Again, it can also, again lead to neuropsychiatric adverse effects such as suicidal ideation, but again recent research have found that they may not actually worsen it, but one should tell the patient and make the patient aware. Now contraindication of bupropion in seizure disorder, because we learned in depression also that high dose can cause seizure, and also these are contraindicated in patient having bulimia or anorexia nervosa, eating disorder, because the risk of seizure may increase in these disorders. Let's talk about club drugs. Now many category of drugs are included under club drugs. So these are the drugs basically which are associated with dance clubs or dance parties. So rave parties, also known as rave drugs. So let us try to remember. So let's try to remember some of these drugs by ABCD. So since these are club drugs, let us forget A and B and let's start with C and D. So EFG, let's hijack, let's forget HIJ, and then it's KLM. So what are these club drugs? E is ecstasy or methylene dioxymethamphetamine, MDMA. F is flunitrazepam, also known as ropepanol or Rufus. G is gamma hydroxybutyrate or GHB. Then K is ketamine, L is LSD, and M is methamphetamine. Okay, so these are some of the important club drugs. Then there are certain drugs known as date rape drugs. These produce disorientation and sedating effect, and the person generally does not know, during the effect of these drugs what is happening around. These are date rape drugs. So again, from these list only you can remember with the mnemonic KGF. So what are these drugs? Ketamine, GHB, and flunitrazepam. Then there are certain newer disorders like gambling disorder. So what is gambling disorder? As the name says, persistent or recurrent gambling behavior, which may be online or offline, and it is, there is impaired control over gambling and it takes precedence over other activities, and the person is continuously doing it despite negative consequences. Then we call it as gambling disorder. And gaming disorder, again, it's a new diagnosis in ICD-11. So what is gaming again? Persistence or recurrent gaming behavior, which may be digital or video games. It can be online or over the internet, or offline. So again, the behavior is taking precedence over other activities, difficult to control and leading to negative consequences. That is gaming disorder. Again, in treatment of gambling or gaming disorder, therapy is the treatment of choice. Now let us discuss some important topics of child psychiatry. First topic which we'll cover is attention deficit hyperactivity disorder, that is ADHD. The older name was minimal brain damage or minimal brain dysfunction. It is a neurodevelopmental disorder. Now this is important that it is not a behavioral problem, it is a neurodevelopmental disorder. Now, what are the clinical features? As the name suggests, there is attention deficit, so there is inattention, and there is hyperactivity. So the first symptom is inattention. So child presents with complaints from parents, from teachers, that the child fails to give close attention to details. So because there is inattention, the child is not able to pay attention to such details or makes very careless mistakes because of inattention. Then child may have difficulty sustaining in attention in a task, so child is doing something and subsequently may start doing something else because he is not able to pay attention for a long time. Difficulty to finish the task. And these children may get easily distracted. So in the class, many times teacher may report that they are teaching and the child is watching something outside the window. So they get easily distracted. Second symptoms are hyperactivity and impulsivity. So what is the child with hyperactivity may represent with? So they may be the child may fidget or, may just tap hands or feet, may not be able to, even if the child is sitting, may continuously move. The child is very fidgety. Then these may leave the seat when remaining seated is expected, like in a class, when everyone is sitting, these, children may just stand and start moving. Then, again, a very common complaint from the parents, the child is always on the go. The child is acting as if, the child is driven by motor. So many times, parents say, how to stop this? So they are always, in a move. Also, they may talk excessively. Then these children may also be impulsive. So this may present like symptoms like they interrupt others. So two people are talking and they may interrupt. They may have difficulty in waiting for their turn. Or, the teacher is asking a question, before completing the question, they may just blurt out some answer. So there may be impulsivity. Now, in DSM-5, the onset of symptoms to make a diagnosis of ADHD in a child should be before 12 years of age. So any child in which we are making a diagnosis of ADHD, symptoms should start before 12 years. This is important because before this in DSM-4, this cutoff was 7 years. So now this is increased to 12 years. So anybody who has developed symptoms after 12 years, we will not diagnose it as ADHD. Second is, this is in fact also added in ICD-11 that symptoms should be present in at least 2 or more settings or situations. So let us say the symptoms are present at home and they are also present at school. Symptoms are present at home and they are also present in a playground. So at least in 2 situations, these symptoms should be present. Then we say that the child is having ADHD and these symptoms should continue for at least 6 months. Now, then subtypes based on the predominant symptom. The child may have combined presentation where there is symptoms of inattention and hyperactivity, impulsivity. Some children may just have predominantly inattentive symptoms or some may have predominantly hyperactive or impulsive symptoms. Now, these symptoms, in fact, most of these childhood disorders are more common in boys than girls. We'll discuss some of the exceptions. Now, the course, 40% of the cases show remission at puberty or in early adulthood. So, symptoms may gradually remit, but some children may continue to have these symptoms and they may continue in adulthood. That is known as adult ADHD. Hyperactivity is usually the first symptom which remits and inattention is usually the last symptom to go away. The remaining cases, they show partial remission and they are at risk of developing certain disorders like antisocial personality disorder, substance use disorder, even mood disorders. Now, treatment, ADHD again is a very serious medical condition. Serious does not mean we are talking about life and death. But again, in this crucial years of learning, the child is not able to pay attention to so much important information, things around, is not able to learn so many skills. So it is a serious condition, it requires treatment. And the treatment of choice is pharmacotherapy. So pharmacotherapy is considered the first line of treatment for ADHD. So we have two types of drugs which we use. One is CNS stimulants and the other is non-stimulants. So let us discuss three drugs each we will discuss. So under CNS stimulants, these are the first choice of drugs. They should be avoided, should not be used in a known cardiac risk or abnormality. So if a child has a cardiac risk, you should not use. Or suppose there is a family history of sudden death, there is some cardiac risk in the family, again, then you should not use these CNS stimulants. And also you should avoid giving these stimulants at night time because these are stimulants. The child may improve with symptoms, but the complaint may be of insomnia may come if you give at night. So usually in the morning, in the afternoon we give. The first drug is methylphenidate, which is also the drug of choice for ADHD. It is a dopamine agonist. Some of the common side effects like headache, nausea, insomnia can occur. It can also exacerbate tics. So tics are basically motor movements or vocalizations which occur. Then if the child develops tics, then of course we should find some other options which we'll discuss. And also it can cause growth suppression. So you're treating a child with ADHD with methylphenidate, the symptoms are improved, but what the parents complain that the size or the weight of the child is not growing as other children. So it may cause growth suppression. In that case, we use a strategy known as drug holiday. So what we do is we give holiday from drug. So we tell the parents stop giving the drug in the weekends, stop the drug during the summer vacations and winter vacations, so wherein the growth will come back. Second drug under CNS stimulants is amphetamine. It is the second drug of choice if methylphenidate fails. It is also a dopamine agonist. Third is modafinil. It is an alpha-1 agonist. Now, it may help in adult ADHD, but it is not FDA approved. While both the above mentioned drugs, methylphenidate and amphetamine, those are FDA approved for ADHD. But yes, this can still be used. Next is non-stimulants. So now these are useful in patients where stimulants have poor response or they are avoided due to side effects, for example, tics, or where they are contraindicated. The stimulants are contraindicated like cardiac illness. So then we can use non-stimulants. So first drug is atomoxetin. It is a norepinephrine reuptake inhibitor. One of the important risks is it can increase suicidal ideation. So one should be careful about it. Second is alpha-2 agonists. So these are presynaptic agonists like clonidine, guanfacine. These may have common adverse effects like sedation, headache, fatigue, hypotension. Again, you can remember clonidine, these drugs are used for hypertensive patients, so they can cause hypotension. Now they are preferred in comorbid tic disorder. Okay, so in such disorders when stimulants cannot be used, because clonidine also takes care of the tics. In fact, clonidine is a first line drug for treatment of tic disorder. Also, these can be used in night time because they cause sedation. Atomoxetin also decreases tics, but if you have to choose between atomoxetin and clonidine, you can go with clonidine because clonidine not only do not exacerbate tics, it in fact is used in the treatment of tics. So clonidine may be preferred. So let us accumulate the uses of clonidine. We have discussed in psychiatry. It can be used in tic disorders like Tourette syndrome. It can be used in ADHD. We have discussed. Also, we have discussed in substance use disorder to take care of the withdrawal symptoms such as in opioids. It can be used. Now, third drug under non-stimulant is bupropion. It is an NDRI. It's an antidepressant. Again, we have discussed. Again, risk of seizure at higher doses there. Again, it is also the third drug in each the category are not FDA approved. So let us compile the uses of bupropion which we have discussed. It is an antidepressant. We have discussed it in smoking cessation and also now we are discussing ADHD. Now next is autism spectrum disorder, previously known as pervasive developmental disorders or PDD. Now these are also neurodevelopmental disorders. So there are two core symptoms. You can remember two symptoms in ADHD, two symptoms in autism spectrum disorder. So these are deficit in social communications and restricted repetitive behaviors. So child with deficit in social communication may present with poor reciprocal social skills. So social skills are very poor. So in infants, they may, even in infancy, we can sometimes identify autism spectrum disorder. Okay, so infants lack poor smile. Then they may lack anticipatory posture for being picked up. So many children who are being picked up, you do like this, they will try to make an anticipatory posture, but these children may not make this posture. There is problems in social communication. Then poor eye contact, there may be poor attachment behavior. So if parents are not there, even then they don't care. It doesn't matter to them. Even if they're with strangers, it doesn't matter. So poor attachment behavior, social behavior is very awkward. They may have difficulty making friends or getting into relationships. Second symptom is there is a restricted repetitive pattern of behavior or interest. So there are certain things which they would do again and again. So these children, their activities are very rigid, very repetitive, very monotonous. They often may play with toys in a very ritualistic manner. You give a child with autism a toy car, let us say, he may just take out the tire and just play with the tire. Give him any type of toy car, he may play in a similar manner. So they play in a very ritualistic manner. They have a lot of stereotypic movements, mannerisms may be there, so repeated movements, and they may enjoy repetitive activities like spinning, banging. So these things may be seen in these children. Any change or any disturbance from their daily routine. So, they will have a very fixed type of daily routine. So any daily routine, if it is changed, it may upset them and may cause panic, fear. So you tell a child with autism that, we are changing your furniture of the room, or we are changing your room, or we are changing house. So these children may react in a very, very panic or fearful manner. Now, autism spectrum disorder. So please understand. So what is the spectrum disorder? Basically, what DSM-5 and ICD-11 have done, they have combined certain disorders together. So there are two core features in these disorders which we have discussed. Earlier, there was a third criteria, that was language impairment, which now has been removed from the core features both in DSM and ICD-11. So it's not a defining feature anymore. It may be seen in the children with autism spectrum disorder, but it's not a defining feature. So there are only two core features. Now, there may be certain associated features, like there may be higher incidence of abnormal dermatoglyphics, like abnormal fingerprints may be there. Intellectual disability may be seen in 30% of the patients. There may be symptoms like irritability, aggression may be seen in these children. The genetic factors, most common genetic factor associated with autism is Fragile X syndrome, and also tuberous sclerosis is also associated. Now, so there are 5 overlapping disorders, which is autistic disorder, Rett syndrome, childhood disintegrative disorder, Asperger disorder, and PDD-NOS, that is pervasive developmental disorder, not otherwise specified. So what has been done is all these are put in a single diagnosis, both by DSM-5 and ICD-11. They were similar, so they've been kept in a single diagnosis of autism spectrum disorder. So autism we have discussed, the two common features, core features would be seen in all these. Now, autistic disorder or autism or childhood autism, it is seen. So most of these disorder, in fact, they are seen in more in boys than girls. One exception is Rett syndrome. Again, there are very unique characteristics of Rett syndrome which we will discuss. So autistic disorder or simply autism or childhood autism usually have an onset before 3 years of age. And again, these children may also have, many of them may also have mental retardation, and a lot of genetic factors may also be seen in these disorders. Now let's talk about Rett syndrome. Now Rett syndrome, it is one exception wherein it is more common in females than males. In fact, initially it was believed that it is only seen in females, but now we know that even males having similar symptoms have been identified. Now, there is a mutation which has been identified. There is an X-linked gene encoding MECP2, methyl CpG binding protein 2 mutation has been identified in Rett syndrome. So again, Rett syndrome will have those two similar characteristic core features which we have discussed: deficit in social communication and repetitive restrictive patterns of behavior. Along with this, some interesting things which are seen in Rett syndrome, that from birth to the first 5 months, everything seems to be normal. The development in all the areas is normal. Problem starts from 6 months to 2 years, which is characterized by there is loss of acquired motor skills. So whatever motor skills the infant had developed, those will be lost, and these will be replaced by certain stereotypic repetitive odd movements such as hand wringing. So hand wringing, again, these are midline movements. These are stereotypic movements which may be seen. There may be loss of acquired speech. Whatever speech the child has acquired, that will be lost. Another interesting point is that the head circumference growth will de-accelerate. So what will be the finding which will be seen? Microcephaly. So very important. And please remember, microcephaly is not seen at birth. So as we discussed, till 5 months, there is everything normal. So it is occurring afterwards, in 6 months to 2 years. So microcephaly. And also may develop poor muscle coordination, ataxia. Seizure may be seen as high as 75% of these children. And EEG abnormality may be seen nearly in all the children. Now let's talk about the next disorder, that is specific learning disorder. ICD-11 calls it as developmental learning disorder. So as the name suggests, SLD or specific learning disorder, there is some problem in area of learning. It is also a neurodevelopmental disorder. Again, the child is not intentionally doing things, family members may think, the child is just being mischievous. No, it's a neurodevelopmental disorder. So there is persistent difficulty in learning academic skills such as reading, written expression, or mathematics. And these are inconsistent with the intellectual ability of the child. Usually it is not because of poor or low IQ. So intellectually the child may be normal. So these are neurodevelopmental disorder which may occur in the child. So again, it may be of various type. Specific learning disorder with impairment of reading, that is known as dyslexia. So there is problem in reading. So child is having difficulty in recognizing words. The child is not able to recognize whether this is B or this is B. There may be poor comprehension, difficulties with spelling. So the child is having difficulty in reading. Then child may have difficulty in written expression, known as specific spelling disorder. So there may be very poor writing skills. Spellings may be very poor. Again, if you ask the child to write phone, the child may write like this on one page, may write like this on one page. If you see the handwriting again, the handwriting may be very poor. So there is problem in written expression or writing. Then child may have difficulty in mathematics or dyscalculia. So difficulty learning numericals, difficulty remembering signs such as whether this is plus, this is minus. There may be slow and inaccurate calculations. So child has poor mathematics skills. And next, the child may have mixed disorder of scholastic skills. Okay, child may have mixed disorder of scholastic skills. So there is combined impairment of reading, written expression and mathematics. So some children may have problems in reading and writing, reading mathematics, writing and mathematics, or maybe all will be seen in the child. Now let's talk about intellectual disability. Okay, so DSM-5 uses this term intellectual disability or intellectual developmental disorder, while ICD-11 uses the term disorder of intellectual development. And both these terms replaces the old term, previously it was known as mental retardation. So please remember, mental retardation has now been given a new name, intellectual disability. Now what is mental retardation or intellectual disability? There is significant limitation in both. First, there is limitation in intellectual functioning of the child. So reasoning, learning, problem solving, those are impaired. And also adaptive behavior such as conceptual, social and practical skills, day-to-day skills, those are also impaired. So both intellectual functioning and adaptive behaviors are impaired. And the onset is usually before 18 years of age. Now intelligence is usually measured by calculating IQ. What is IQ? IQ is intelligence quotient. And how do we calculate? By mental age upon chronological age into 100. So chronological age is basically the age which we calculate from date of birth upon. So it is divided by, so mental age upon chronological age into 100. And in the numerical, please remember the chronological age should not be more than 15. Suppose you are calculating an IQ of a 17-year-old child. Mental age is, let us say the mental age is 5. The child is 17 years of age. So IQ would be mental age upon chronological age. So chronological age will not be more than 15. So this is how we'll calculate the IQ. Or it is written as MA upon CA into 100. Normal IQ is between 90 to 109. Borderline IQ is 70 to 89. So mental retardation is when the IQ is less than 70. Now let us see the severity based on the IQ. So mild, moderate, severe and profound mental retardation. So IQ in mild mental retardation is, so it should be less than 70, 50 to 69. Moderate is 35 to 49. Severe is 20 to 34 and profound is less than 20. Now also please remember that nowadays it is not mandatory that the severity should be based on IQ. So DSM-5 in fact says that the adaptive behavior of the child may tell us about the severity. So child with mild mental retardation may have less impairment in adaptive behaviors, while profound may have severe impairment in their adaptive behavior. So IQ is not necessary to make the diagnosis of severity. The genetic factors, most common genetic factor associated with mental retardation is Down syndrome, and second is Fragile X syndrome. Now coming to the treatment, again we don't have any cure. So psychosocial interventions are the interventions which we use. So behavior therapy is one of the therapies, especially for maladaptive behaviors such as aggression, self-injurious behavior may be seen in the child, or hyperactivity. So we use behavior therapy, and one of the type of behavior therapy we use is contingency management. So what is contingency management? Basically, the desired behavior is rewarded. So if the child do something which is a desired behavior, we reward it. Let us say we give him a chocolate. So that will increase that behavior, while undesired behavior are punished. Again, we don't use harsh punishment. So to reduce the undesired behavior, we give some punishment. So contingency management. Now pharmacotherapy again can be used for symptomatic treatment. So for example, if a child is having aggressive behavior, we may use low doses of antipsychotic. If there is anxiety, depressive symptoms, we can use antidepressants, or we may use benzodiazepines. Like for example, there is problems of insomnia. So symptomatic treatment may be done with pharmacotherapy. So now let us discuss organic mental disorders. So organic mental disorders in DSM-5 and ICD-11 are known as neurocognitive disorders. So it's a very apt name given. So there are cognitive symptoms or subcognitive dysfunction because of neurological causes. So neurocognitive disorders. Now 3 disorders are included. One is delirium. then dementia and amnestic disorder. So try to understand, just if you understand the crux, it becomes very, very simple to understand these disorders. So if you see in delirium, there is impairment of both consciousness and cognition. It's a cognitive disorder, neurocognitive disorder. So along with cognitive impairment, there is also consciousness which is impaired. While if we see in dementia, it is only the cognition which is impaired. Consciousness is not affected. While in amnestic disorder, only memory is affected. So cognition has various domains. One of them is memory. So one of the functions of cognition is memory. So in amnestic disorder, as the name suggests, there is only amnesia. So in cognition also there is just memory impairment. So if you see this flow, you will understand these three disorders. So let us discuss some of the important points. First is delirium, very important. Now delirium is the most common organic mental disorder. It has an acute onset. So you will find the symptoms may start within few hours or within few days. So acute onset. And the course is often fluctuating. That means the symptoms are not constant, they may fluctuate. They may go up and down. Symptoms may increase and decrease in the daytime, during the day. So progression is fluctuating. Now, before coming to the symptoms, there may be many predisposing factors which may be seen. Now, organic mental disorders, basically what we are trying to say is that there is some cause, some visible demonstrable cause which is causing the symptoms. So organic mental disorders. Now in delirium, there may be certain predisposing factors, okay, which may be given in the question or clinically you may see. So it may be seen more in elderly age. There may be history of some medical illness like pneumonia, or there is history of burns. Also sometimes they may be associated with surgical illness. Again, in the question you may find that the person is having some bypass surgery, or there is history of fracture femur, or there is a roadside accident, or there is appendicectomy. Okay, so such surgical illness may be given, or after post-operative period. So it may be given that 2 days after the operation or 2 days post-operatively the person develops some symptoms. So these again very important, these may be given in the question. Such factors may be given which may lead to delirium. Then also sometimes substance use, especially alcohol. In fact, alcohol withdrawal may lead to delirium tremens, which we have discussed in substance use disorder. So these are some of the predisposing factors which may be seen. Now let's come to the diagnosis of delirium. So in diagnosis, first is very, very important is there is impairment of consciousness. This is very, very important. So look for this symptom. So let us try to understand how in the question you may find that there is impairment of consciousness. So they may mention that there is clouding of consciousness, or there is confusion, or there is altered sensorium, or there is reduced orientation, the person is disoriented. So these are the symptoms which may tell us that there is impairment of consciousness, which is a very important symptom for diagnosing delirium. So please look at these symptoms, and if it is present, think of delirium. Then there is also attention which is impaired, so there may be reduced ability to focus, sustained or shift attention. So in clinically what you will see is if you are asking some question to the patient, you may have to repeat multiple times because the attention is impaired. And of course, it's a neurocognitive disorder. So cognitive impairment is also there in the form of, so we'll discuss various domains of cognition. Some of them like memory is there, especially recent and immediate memory is impaired. Remote memory may be intact. Then language impairment, perception impairment may be there, illusions, hallucination. What type of hallucination you will find more commonly in such patients? Visual hallucinations may be more commonly found in such patients. So patient admitted in the ICU, there is impairment of consciousness, inattention, and the person is seeing snakes on the bed. So visual hallucination may be seen in these patients. Along with these symptoms, other symptoms like motor disturbances, motor activity may be increased or decreased, or sleep disturbances may be there, or emotional disturbances may also be associated with delirium. Now in the assessment, there is a screening, there is a tool which is used to diagnose, that is confusion assessment method, or CAM. As the name suggests, confusion, what are we trying to assess? We are assessing delirium. Okay, so it may be used to identify delirium. Then on EEG, that is electroencephalogram, there may be diffuse slowing of the background cortical activity. So in all the causes of delirium, you may find that there is a diffuse slowing of the background cortical activity, except one delirium, which is caused by alcohol or sedative hypnotic withdrawal like benzodiazepine. In those delirium, there may be low voltage fast activity. Other than that, all the causes of delirium will have slowing of the background activity. Now coming to the treatment, it's a reversible condition, but again it can, its very mortality may be high. So again, it is important to identify the cause. So whatever may be the cause, look for the cause, investigate it and treat the cause. So it may be because of some CNS cause, it may be because of some systemic cause, some infection. So whatever is the cause, treat the cause. And pharmacotherapy we can use for certain symptoms, like antipsychotics may be used for management of certain symptoms like delusion, hallucination or agitation. Benzodiazepines may be used for treating insomnia. And in fact, we have already discussed one delirium in which benzodiazepines are the drug of choice is the delirium tremens. For that, benzodiazepines are actually the treatment. So drug of choice will be benzodiazepine in delirium tremens. Let's talk about dementia. So dementia is the second neurocognitive disorder. So there is progressive cognitive impairment in clear consciousness. We have discussed the consciousness is not impaired in dementia, only cognitive impairment. And so the symptoms of dementia, there is only cognitive impairment. So you can remember it with the mnemonic memory lapse. Now please remember that dementia does not just mean memory impairment, but the mnemonic you can remember it with memory lapse. So these are the cognitive domains which may be affected. So memory is affected, so it is known as, let's try to correlate these terms. So it is known as amnesia. There may be language impairment known as aphasia. So complex attention may be impaired. So complex attention is focusing on multiple stimuli. For example, right now you're watching the video, you're also listening to it. You may also be writing your notes. So multiple stimuli you are focusing on. So a person with dementia may not be able to do this. So complex attention is impaired. Perceptual motor system is affected. So how the symptoms will be presented with apraxia, problems in fine movement, agnosia, difficulty in identifying objects or faces. Such symptoms may a person present with. So these are the symptoms. Then social cognition. So social cognition is recognition of emotion is impaired. So family members may report that we cry in front of the patient, but the person does not show any affection because he is not able to recognize emotion. And executive functioning, planning, decision making, again those may be affected. So please see, memory is not just the only domain which may be affected, other domains may be affected. So 60-year-old, 65-year-old male with complaints of memory loss, difficulty in language, difficulty in untying his buttons, tying his shoelaces, combing hair. So apraxia, fine movements is lost. Then is not able to recognize objects. So what is the diagnosis? Dementia. Now, to make the diagnosis, only cognitive impairment is necessary, but yes, these patients may also have certain behavioral and psychological symptoms like personality changes, delusions, hallucinations, depression, anxiety symptom, agitation, aggression. These may also be there, and it is important because in treatment we also have to manage these symptoms. Now, what is early onset dementia? Onset occurring before 65 years of age, we call it as early onset dementia. Usually dementia is a disorder of later age. So prevalence increase with age, but some patients may develop dementia early. Those are known as early onset dementia. Now, in types of dementia, there are certain dementias which are reversible. In fact, most of them are progressive, but 15% may be reversible. It is very important to identify these reversible causes because we can treat them. Otherwise, we cannot stop the progress. So, like neurosurgical conditions, for example, there is some hemorrhage, subdural hemorrhage, or there is some brain tumor. We treat it, the symptoms will be relieved. There may be infections like encephalitis. Then metabolic causes, again two important symptoms like deficiency of vitamin B12. Again can lead to dementia. You correct it and symptom will be reversed. Other deficiency like folate, niacin may be seen. Then hypothyroidism again may be associated with dementia. Other endocrinal abnormalities may also be associated like hyperthyroidism, hypo and hyperparathyroidism. But again, hypothyroidism again very important. Other causes like even alcohol. Chronic alcohol use can also cause dementia and it is also reversible. You stop alcohol and within a year it is seen that the changes which have occurred will be reversed. So these are some of the reversible causes. Another classification of dementia is cortical and subcortical. As the name suggests, it is based on the site of lesion. Cortical, it is the initial involvement, early involvement is cortical structure. Later on, all the structures may be involved. Similarly, in subcortical, there is initial involvement of subcortical structures like basal ganglia, brainstem, nuclei, cerebellum. So initially they are affected, then gradually even the cortical areas may get affected. Now, examples, Alzheimer's disease is a type of cortical dementia. In fact, it is overall most common cause of dementia. Okay. Then Pick's disease. Pick disease is also known as frontotemporal dementia. So the name is telling you it is a cortical dementia. Then subcortical dementias like Parkinson's disease, Huntington's chorea, multiple sclerosis, progressive supranuclear palsy, Wilson's disease, all these are subcortical dementia. And please remember, in cortical dementia, the motor system initially usually is normal. While if you see most of these disorders, the presentation is usually motor abnormality. Why? Because the subcortical structures are getting affected, like basal ganglia. So motor symptoms are more commonly seen in the initial presentation. So again, just by looking at the symptoms, sometimes we can differentiate whether it is cortical or subcortical. Then there are certain mixed dementias like vascular dementia, Lewy body dementia. These are mixed type of dementias. Alzheimer's disease, it is overall the most common type of dementia. Even it is the most common type of early onset dementia. It has a gradual and insidious onset, so slowly progressive disease it is, and it is seen more in females than males. It has a parieto-temporal distribution. So initially the parietal temporal lobes are affected and gradually the entire cortex may be involved. Most common presentation is cognitive symptoms like memory deficit, language disturbances may be seen initially. Now in the neurotransmitters, there is decrease in the acetylcholine and increase in the glutamate. So again, we will use this when we will talk about the treatment. Since there is decrease in the acetylcholine, so in the treatment we have to increase it. And again, there is increase in glutamate. Glutamate is neurotoxic. So we will use some antagonist for the same. So this is how we can correlate. Next is vascular dementia, also known as multi-infarct dementia. It occurs because of vascular event in the brain like stroke, which may be hemorrhagic or ischemic. So interesting pattern which is seen in these patients is step ladder pattern. So step ladder pattern of symptoms is seen, stepwise deterioration of symptoms, which is due to acute exacerbation because of new areas which are affected due to the vascular event. So suppose a patient had a stroke during this time, symptoms increased and they came to a plateau. Let us say after some time, after a few years again, there was another stroke, again symptoms increased and came to a plateau. So this is stepwise step ladder pattern of presentation. Then frontotemporal dementia or Pick disease. Now as the name suggests, there is atrophy of frontal and the temporal lobe, and again Pick disease, it is known as because Pick bodies are seen in the micropathology. Okay. Now frontotemporal dementia usually occurs in early age. So we talked about early onset dementia, when dementia would occur before 65 years of age. So most common cause of early onset dementia was Alzheimer's. Second most common cause for early onset dementia is Pick disease or frontotemporal dementia. It has two variants. So one is behavioral variant, other is language variant. So again, we can understand it like this. So behavioral variants is when mostly the frontal lobe is affected. And if frontal lobe is affected, please see, and again important, what kind of symptoms may occur? Disinhibitory behaviors may occur. Certain behaviors which usually we inhibit ourselves. For example, a person goes in public and starts urinating. Which lobe is affected? It is the frontal lobe. Then apathy, stereotypic behavior, even hyperorality. Such behaviors may be seen with frontal lobe involvement. While in language variant, which lobe is affected? It is the temporal lobe which is affected, leading to symptoms of language impairment. Next, again very important, Lewy body dementia. It is now the second most common cause of dementia. After Alzheimer's, this is the second most common cause, Lewy body dementia, dementia of Lewy body. The core features of Lewy body disease is three core features. There is fluctuating cognition. So the cognition is impaired and they are also fluctuating. So symptoms are increasing, decreasing even during the daytime. So there is variation in attention, alertness. Please see, visual hallucination is there in the core feature. So we have discussed multiple times in organic mental disorders, visual hallucinations are more common. In Lewy body disease, in fact, it is there in the core criteria. And motor features of Parkinsonism like tremors, rigidity, bradykinesia, these may be seen. So these are the three core features of Lewy body dementia. Then it has some suggestive features. One is REM, sleep behavior disorder. So REM, sleep behavior disorder may be seen. Generally in REM, there is atonia. So the muscles, the body is in a state of paralysis. But if the muscle paralysis does not occur completely, so what happens? There are dreams and the person starts enacting like the person is punching, kicking in the sleep. So such REM, sleep behavior disorder may be seen. Also severe neuroleptic sensitivity may be seen. So they are sensitive to neuroleptic, that is antipsychotic, which may induce EPS. So they are sensitive to neuroleptic induced extrapyramidal symptoms. So patient is having visual hallucination, you think of giving antipsychotic, person may develop extrapyramidal symptoms. So if you have to give, be very careful and also try to give in low doses. Pathology wise, we'll see Lewy bodies. These are eosinophilic inclusion bodies. Now, normal pressure hydrocephalus, again, it is one of the types of causes of dementia. It is a reversible cause. Okay, it's a neurosurgical cause. Normal pressure hydrocephalus, NPH. It has a triad of abnormal gait. There is abnormal gait, dementia, and urinary incontinence. And generally, treatment is ventricular shunting. Now, assessment of dementia. So we assess dementia. So mini mental state examination is a screening tool which is used to assess cognitive functions. It has a total score of 30. Any score less than 24 is suggestive of dementia. Then again in the treatment is treat the cause. So we know that some of the causes are reversible. If you're able to find a reversible cause, treat the cause. Vitamin B12 deficiency, hypothyroidism, NPH. So if there is a reversible cause, treat it. In pharmacotherapy, we have two types of drugs. One is cholinesterase inhibitors. These are reversible inhibitors of enzyme acetylcholinesterase. So in this reaction, acetylcholine is broken down to acetyl and choline by this enzyme. So what we are doing, we are inhibiting this enzyme, inhibiting this reaction. So ultimately we are increasing acetylcholine. So this is what we need, because we have discussed the acetylcholine is reduced. So we are increasing it. So this is how we can correlate. Now in this category, one drug is tacrine. This is not used nowadays because of hepatotoxicity. Other drugs include like donepezil, rivastigmine, galantamine. Then another drug is mementin. So what is the mechanism of action mementin? It is an NMDA antagonist, non-competitive NMDA antagonist. So NMDA is a glutamate receptor. So we've discussed glutamate is increased. So we're using an antagonist. So this is how we can always correlate. Now for behavioral and psychological symptoms, we can use antidepressants if there are depressive symptoms, antipsychotic for delusions, hallucinations, aggression, benzodiazepine for insomnia. So we can also manage these behavioral and psychological symptoms. Let us talk about the third organic mental disorder, which is amnestic disorder. As the name suggests, there is only memory impairment. So out of the cognitive functions, only memory is getting affected. So especially recent memory, so inability to learn new things, anterograde amnesia is there. Also reduced ability to recall past events. So retrograde amnesia is also seen. What all things are intact in these patients? First, there is intact immediate memory. Consciousness is intact, because if consciousness get impaired, the diagnosis will be delirium. And other intellectual functions, global intellectual function, they are also intact. So other than memory, the other cognitive functions are not affected, because if they get affected, then the answer would change to dementia, because two symptoms are now getting affected. Okay, so only memory is getting affected. Causes may be CNS causes like seizures, trauma, tumors, infections, and systemic causes. One important interesting cause is thiamine deficiency. So even in alcohol induced cognitive disorder we have discussed, thiamine deficiency can lead to Korsakoff syndrome, and the symptom which we have discussed was amnesia. So that was a amnestic disorder, Korsakoff syndrome. So again, in the treatment we will treat the cause. So now let us talk about the next topic, which is sleep-wake disorders. Now sleep is made up of two physiological states. One is NREM, that is non-rapid eye movement, and the other is REM, that is rapid eye movement. So generally when we fall asleep, the first stage we encounter is NREM, then after some time we reach REM, and then these states fluctuate. Initially in the first half of the cycle of sleep, NREM is more, and in the second half of the cycle, REM is more. Now NREM and REM, NREM was earlier divided into 4 stages, but now these are now clubbed into 3 stages. So stage 1 is now known as N1, stage 2 is known as N2, stage 3 and 4 are now combined, known as N3, and the other stage is REM. Now let's talk about some important EEG findings in some important stages. So in NREM, in N2, so N2, there are 2 important EEG findings. So electroencephalogram, if we do in a patient who is in stage N2, we find these 2 findings. One is sleep spindles. So these are burst of waves of 12 to 14 hertz like this, which may occur. And second is K complexes. So these are basically sharp negative waves followed by positive waves. So sleep spindles and K complexes are seen in stage N2. In EEG of REM, there is increased activity which is similar to the awake state, that is beta activity as well as alpha activity seen, which is usually seen when a person is awake. So when a person is awake and the eyes are open, we find beta waves, and suppose you are awake and you close your eyes, you find alpha waves on EEG. But these two findings are seen in REM. So this is again very paradoxical. So person is sleeping but the EEG is showing as if the person is awake. So that is why REM is also known as paradoxical sleep. Also, these waves are of specific appearance known as sawtooth waves. So again, sawtooth appearance or sawtooth waves are seen in REM. So again, important. Now let's try to understand some of the difference between NREM and REM. NREM is known as orthodox sleep, the conventional sleep, while REM is known as the paradox or paradoxical sleep. The brain activity, physiological activity like pulse rate, blood pressure, respiratory rate are lower than awake state. As it would be expected in sleep, these phenomena should decrease. Now in REM, these are increased or maybe just like as awake state, except one. So please try to understand this. So the brain activity is as if the person is awake, but the person is sleeping in REM. What if the person may move and harm himself? So what nature has done is, the nature has paralyzed the muscles in REM so that the person may not harm himself. So all of these parameters may be increased except muscle tone, which is in a state of paralysis. There is atonia. Okay. So again, when we see these stages, so body movements would be seen in which stage? In NREM. Usually in NREM we will find the body movements, while REM these will be absent because the body is in a state of paralysis. So most of these disorders, sleep disorders which have movements, would be more likely to be NREM disorders. Okay, so in this way we can remember. Now penile erection occurs in sleep, and when which part of the sleep it is seen? So in males it is seen that penile erection occurs in the REM sleep. Also dreams. Now dreams we see in both the stages, but in one stage, when we wake up, sometimes we are able to remember the dream. Very vividly we'll remember. But sometimes even if we try, we're not able to remember. So dreams of NREM are not remembered. You can remember it like this. And dreams in REM are remembered. Okay. So any sleep disorder in which you remember the dream, it will be of which stage? It will be a disorder of REM. While any disorder in which you are not able to remember the dream, it will be a NREM disorder. So this is how we'll correlate things. Now, some of the disorders of NREM and REM like somnambulism, night terror, bruxism, nocturnal enuresis, somniloquy. Then REM disorders like narcolepsy, nightmares. REM sleep behavior disorder is the one in which you may find movement, because what is happening is, basically in REM sleep behavior disorder, the muscle paralysis which usually occur in REM is not there. So a person is sleeping, he is having dreams, and the person may start enacting the dreams, may start punching, kicking. So in that REM disorder, we may find some movement. Otherwise, most of the movements will be seen in NREM disorders. Now, parasomnias, these are disorders of partial arousal, as if the person is partially aroused, but the person is actually sleeping. So these are of two types, NREM related parasomnias and REM related parasomnias. So in NREM related parasomnias, disorders like somnambulism. Somna means sleeping, ambulism means movement. Okay, ambulance. So it is also known as sleepwalking. So person engage in motor behaviors while the person remains unconscious. This is very important. So the person may just get up and start moving, but the person is unconscious. The person is still sleeping. So person is involved in certain activities. It may be simple walking or may involve complex activities like he may just open the door, step outwards, or go to the kitchen, open the fridge, put something on the plate and put it on the table. So such complex activities may be seen, and they're difficult to awaken. If you try to awaken, they may appear confused and they may even attack you. So guide them towards the bed. Usually it seems to have spontaneous remission over the time, and sometimes if required, treatment may be in the form of benzodiazepines. Then sleep terrors or night attack. Here there is sudden arousal with fearfulness. So person may scream, cry in panic symptoms, and if you try to awake, the person may again appear confused. And if the person wakes up and person is not able to remember the dream. So please remember, not able to remember the dream, it is a disorder of NREM. Bruxism, teeth grinding in sleep. So grinds, there is movement. Okay, so again this is NREM disorder and may damage the enamel. So you may give some teeth covers so that the teeth is protected. Somniloquy or sleep talking. The person is sleeping and the person is talking during the sleep. Again, there is movement. It is a NREM disorder. But when the person wakes up, he is not able to remember what he was saying. So this is somniloquy or sleep talking. Then REM related parasomnias. One is nightmare disorder. So in nightmare disorder, again, there is sudden arousal with fearfulness, but the person is able to recall the dream. Okay, so as if the person had seen a bad dream or a nightmare. So this is nightmare disorder. It's REM disorder. Now next disorder under REM is narcolepsy. Very, very important. Narcolepsy has a tetrad of symptoms, 4 symptoms. First is sleep attacks. It is the most common symptom. So as if the sleep is attacking. So there is a strong urge or desire to, having excessive daytime sleepiness. Person is walking to the office and suddenly there is an urge to sleep. The person may sleep on the roadside. So there is sleep attack, as if the sleep is attacking the person. Second is cataplexy. Please remember this. We have discussed in basically we're discussing catatonic symptoms, something known as catalepsy. So please remember, in narcolepsy, we don't find catalepsy. We find cataplexy. So what is cataplexy? There is a sudden loss of muscle tone. So in narcolepsy, please see what is happening in REM. There is a state of paralysis. So although the person is awake, as if REM is entering the patient. Okay, so person is wake, sitting or standing, and suddenly there is loss of muscle tone. Person may fall, and these often are triggered by emotional outbursts. So for example, somebody cracks a joke or everyone starts laughing, and one of the person, he just might fall. This is cataplexy. Next is sleep paralysis. Please remember, the first symptom was sleep attack. This is sleep paralysis. So person wakes up. So person was sleeping in the bed. Person opens the eyes. He's awake. But what he experiences, he's unable to move his body. So as if the body is in a state of paralysis. So as if the REM has still continued in the wakeful state. So person is not able to move the body. Again, a very frightening experience for the patient. Lastly, patient may experience certain hallucinations which occur at a particular time. Hypnagogic, you can remember, it occurs while the person is going to sleep. So person is falling asleep and suddenly he experiences some hallucination like hearing some voice or seeing something. Okay, so any type of hallucination. Or hypnopompic, where it occurs when the person is coming out of sleep. Okay, so person wakes up and he experiences some hallucination. So these are the 4 symptoms which a person may experience in narcolepsy. It occurs because of deficiency of a neurotransmitter It occurs because of deficiency of hypocretin or orexin. Where it is deficient, hypocretin, deficient in hypothalamus. Now coming to the treatment again, we advise the patient to take forced naps at regular intervals so that excessive daytime sleepiness can be taken care of, so that the person does not fall asleep in places where it is not required. For example, the person is driving. What if the person falls asleep? Then in pharmacotherapy, we can use drugs like modafinil. It's one of the first line drug. It's a stimulant. So we want the person to be awake. So this is used. It's an alpha-1 agonist. Now another sleep disorder is Kleine-Levin syndrome. So it is characterized by episodes of hypersomnia, hyperphagia, person is eating, hypersexuality, and sometimes disinhibition or disinhibited behavior, like a lot of aggression may be seen. And in between these episodes, the patient is asymptomatic. So this is Kleine-Levin syndrome. Now let's talk about some important sexual disorders. Now, phases of sexual response cycle, let us understand. So if a person engages in sexual activity, what are the phases? First is desire phase. As the name suggests, it includes sexual urges, wishes. Second is stage of excitement or arousal phase. So there is a subjective feeling of sexual pleasure, which is accompanied by physiological changes like increased heart rate, blood pressure, temperature, respiratory rate, excessive sweating. Along with this, some important changes may occur in males and females. Like in males, there may be penile erection, and in females, there is vaginal lubrication. So penile erection occurs in excitement phase. Now, also we can correlate. Suppose there is some problem in erection. So you can remember, erectile dysfunction is a disorder of which phase? It is a disorder of E for excitement. It is a disorder of excitement phase, because in males, penile erection occurs in this stage. So if there is ED, erectile dysfunction, it is a disorder of excitement phase. Third stage is stage of orgasm. It is the smallest stage, which lasts from 3 to 15 seconds. It is a stage of peak of sexual pleasure. Again here in males, there is ejaculation of semen, which occurs, and in females there is involuntary contraction of the lower 1/3 of vagina and contraction of the uterus occur in this stage. Now again, if there is any problem in ejaculation, such as premature ejaculation, then it will be a disorder of what stage? It will be a disorder of orgasm phase. And lastly, resolution. Resolution is, it may take 10 to 15 minutes. So resolution is when the body goes back to the resting state. So all the changes which have occurred in the phases, it will go back to the resting stage. Now let's talk about some sexual dysfunctions. First is male erectile disorder or erectile dysfunction. Now, as the name says, there is marked difficulty in obtaining or maintaining erection during sexual activity which is required for a satisfactory sexual intercourse. Either the person is not able to obtain erection or is not able to maintain erection. Now again, it can be of two causes: psychogenic cause or organic cause. Psychogenic cause by psychological factors such as anxiety, marital problems, and organic cause may include certain medical causes like diabetes, arteriosclerosis. So what is happening basically during erection, there is increase in the flow of penis, so which can be affected by vascular disease, by neurological disease. So these causes may cause organic cause. Also, which is more common, psychogenic cause are more common causes of erectile dysfunction. Now, one simple question which can sometimes help us clinically differentiate whether it is psychogenic or organic is asking the patient, does he experience early morning erections or nocturnal erections? So early morning erection normally occurs when a person wakes up, there may be erection which may be felt. So patient having psychogenic cause will be able to experience them, while in organic cause where vascular or neurological causes are there, they may not be able to experience it. So this may help us differentiate the causes. Also, investigations may be used to record nocturnal erections such as nocturnal penile tumescence or penile plethysmography, which measure the blood pressure of the penis. Then coming to the treatment, again two treatment available options are there. One is pharmacotherapy and psychotherapy. Now in pharmacotherapy we have phosphodiesterase 5 inhibitors, PDE5 inhibitors. Basically these are nitric oxide enhancers that facilitate blood flow into the penis and they enhance the erection. Now again, all these drugs ending with phil like sildenafil, tadalafil, vardenafil, these are phosphodiesterase 5 inhibitors. Then in psychotherapy, we use therapy known as dual sex therapy or simply sex therapy, which was devised by Masters and Johnson. In fact, this dual sex therapy is effective for all the other sexual disorders. And basically why it is known as dual sex therapy, because we don't treat the patient, we treat the couple. So we try to encourage both the partners to be involved in the therapy. So these exercises are called sensate focus exercises and include non-genital stimulation, non-genital sensate focus and genital sensate focus. So sensate focus exercise is used for which disorder? Again, it is used for erectile dysfunction. Now let's talk about another important sexual dysfunction, which is premature ejaculation. As the name suggests, there is persistent or recurrent ejaculation with minimal stimulation before or immediately after vaginal penetration. So premature ejaculation is occurring early, either before or immediately after penetration of penis in the vagina. In fact, DSM-5 says if the ejaculation occurs within less than 1 minute, then it is premature ejaculation or PME. Again, treatment is, we have two options, one is psychotherapy and pharmacotherapy. Important therapies which are used for premature ejaculation, one is squeeze technique, which was devised by Masters and Johnson. So what we do is basically when the male partners get a feeling of impending ejaculation, he himself or his partner squeeze the coronal ridge of the glans and it prevents or inhibits ejaculation. So basically it increases the time period of ejaculation. Another is stop-start technique, which was given by Siemens. So it is known as Siemens technique. Here what happens is when the male part gets a feeling of impending ejaculation, the sexual activity stopped for some time and again it is restarted, okay, once the excitement is decreased. So it is stop-start technique. Again, it gradually increases the time of ejaculation. Now coming to the pharmacotherapy, we use SSRIs and we know SSRIs have one of the sexual side effects that they cause delayed ejaculation, and subsequently the side effect we use because we want to delay the ejaculation. So SSRIs like paroxetine, fluoxetine may be used for treatment of PME. Now then some other sexual disorders like nymphomania. So nymphomania is excessive sexual desire in females. while satyriasis is excessive sexual desire in males. So nymphomania is satyriasis. Now then next is gender identity disorder. DSM-5 calls it as gender dysphoria and ICD-11 causes gender incongruence. So basically what is gender identity? Gender identity means identity of your own gender. So since one has, that of being a male or a female, which usually corresponds, most often to the person's anatomical sex. That is one's gender identity. So in gender identity disorders of childhood, there is marked incongruence between expressed gender and assigned gender. So person is not comfortable. So suppose if there is a male child, he has a male, anatomical sex, he is having difficulty in accepting, or there is discomfort with the male gender. Okay, so it occurs in pre-pubertal children. So there is a strong desire to be of the other gender, and also there is preference of cross-dressing, also for preference for toys or games engaged by the other gender. Person is not comfortable with his own assigned gender. So may have dislike of one's sexual anatomy. Next is transsexualism. So there is a desire to live and accepted as member of the opposite gender, of the opposite sex. And it is usually accompanied by a sense of discomfort or inappropriateness of one's own anatomical sex. So for example, patient may say that, I am a man trapped in a body of a woman. So anatomically the body is of a woman, but the person feels that I am a man. So this such statements may be made by patient with transsexualism. So transsexual identity should have been present for at least 2 years, then we say it is transsexualism. Coming to the treatment again, many times patient insist for sex change. So sex reassignment surgeries can be done wherein the external genitalia are changed. Of course, we cannot have completely changed genital, but we try to change the external genitalia. And hormonal therapy is also usually accompanied by such surgeries. Now let's talk about eating disorders. The first eating disorder is anorexia nervosa. Now, most of these eating disorders are more common in females than males. So again, it is more common in females, and the most common age of onset is around 14 to 18 years. So it occurs in young adolescent females. Now, what are the clinical features of anorexia nervosa? Please remember the name is anorexia, but there is no anorexia or loss of appetite in these patients. It's a misnomer. So what are the clinical features? There is restriction of energy intake of food resulting in significantly low weight than normal. So the patient is not eating energy-rich food and there is significantly reduced weight. ICD-11 in fact mentions that the BMI is less than 18.5 kg per meter square in adult, and the BMI for age is under 5th percentile in children and adolescent. So there is decrease in the body weight. Second, there is an intense fear or of gain of weight or fatness. So person may fear, oh my god, I'm gaining weight, I will become fat. So there is a fear of gaining weight or fatness. There is also disturbance in the body image. So patients often perceive themselves as fat, although the person is significantly low, underweight. The weight is significantly low, but the person may often experience that they are fat or even they are normal, but they may be highly underweight. So there is disturbance of body image. Person perceive themselves as fat or normal. Now DSM-5 and ICD-11, both of them have removed amenorrhea, which was in earlier classification a fourth diagnostic criteria. This has been now removed. So amenorrhea is not necessary to make a diagnosis of anorexia nervosa. Now, many adolescents may have delayed sexual development because they are in a state of starvation, while adult patients may have decreased sexual interest or decrease in the sexual activities. Again, medical complications related with starvation may be seen in such patients because they are restricting themselves of eating energy-rich food. It is of two subtypes. One is restricting type and the other is binge eating purging type. Now in the restricting type, it is seen in nearly 50%. It is most common. So as the name suggests, there is highly restrictive food intake, and sometimes these patients may also do excessive exercise to compensate. Okay, or to not to compensate, but just to decrease the weight because they think that they are fat. Now second is binge eating purging subtype. So in these patients, binge eating and purging may be seen. So what is binge eating? Eating large amount of food in small time. So sometimes, let us say your favorite series comes on, let us say Netflix. So you may watch the entire series, all the episodes in one night. So this is binge watching. So binge eating is eating large amount in short duration. Now the person realize that he has eaten a lot, then the person may do purging. So purging are compensatory mechanisms, for excessive calories, like self-induced vomiting, use of laxatives, diuretics, emetics, or maybe excessive exercises. So these are also seen in bulimia nervosa. Now, course and prognosis. So as we discussed, binge eating and purging is also seen in bulimia nervosa, but how to differentiate? In anorexia nervosa, the other important clinical features which we have discussed, the 3 features, where these are also present. Now, these have high mortality rate, and in books it is written it is as high as any psychiatric illness. So it is one of the psychiatric illness with high mortality rate. And the most common cause of death is medical complication of low weight and malnutrition. Again, these patients are often secretive, they deny their symptoms and even resist treatment. So treatment is very difficult at times. Hospitalization even may be required to restore the patient's nutritional status, manage complications like dehydration, electrolyte imbalance, like hyponatremia, decrease in the potassium, decrease in the chloride ions. And the patients who are admitted or may also be admitted when there is 20% below the normal weight for height. Then also it is a need for hospitalization. Again, the primary goal of treatment is nutritional rehabilitation and weight restoration. And initially we start with low calories, 1500 to 1800 kilocalorie per day, and we divide it in various meals of the day. Now, it is very important to monitor these patients for at least 2 hours after each meal, because many times patient may, after feeding, may go in the washroom or some area and may start doing purging. Okay, so after, let us say, after 1 week, 2 weeks, you see that there is no improvement in the weight. So it may be because of this self-induced vomiting. So always monitor these patients for 2 hours after each meal. So treatment, again, behavioral management, we use behavior techniques, behavior therapy, and SSRIs may be used, which may benefit some patients. Second is bulimia nervosa. Now bulimia nervosa again is more common in females than males, and the most common age of onset is late adolescent and young adult, so slightly late in onset than anorexia. So maybe in 17, 18, 19, 20, 21, this age group, these patients may present with bulimia nervosa. So there is episode of binge eating, so which is combined with inappropriate ways of preventing weight gain or compensatory behaviors. So there is episode of binge eating in which person eats large amount of food, and usually it is consumed in short duration, and basically there is difficulty in self-control. It is subsequently followed by compensatory behaviors to prevent weight gain, like purging methods like self-induced vomiting, use of laxatives, diuretics, emetics, sometimes excessive exercise or fasting may be used. So patient is eating a lot and then is using compensatory mechanisms. And these are done at least for 1 per week for continuous 3 months. Then we say it is bulimia nervosa. These patients may also have some fear of gaining weight or desire to lose weight. Again, they may also have this. But weight usually here is normal or is increased as compared to anorexia nervosa, wherein the weight is decreased. So again, this is one important differentiating factor. Now, features secondary to purging may be seen, such as enamel erosion or dental caries. A lot of vomitus, from the stomach, acidic content is coming in the mouth. So again, there may be poor oral hygiene. Swollen parotid glands and other salivary glands, parotitis may be seen. Now again, interesting sign known as Russell signs. Okay, so there may be callus on the knuckles because of repeated trauma to the knuckles. There may be callus on the knuckles. This may be seen in these patients, which is suggesting the repeated self-induced vomiting. And patients may also show hypokalemia, hypochloremia. HCl is coming out of the body, so chlorine is also low. Hyponatremia, and there is the hydrogen ion they are getting out, so it is alkalosis. So alkalosis is seen in these patients. And many of these complications may also be seen in anorexia. How they are seen in anorexia? Because in anorexia nervosa also there is one subtype, binge eating purging subtype. In those patients even they can have these complications because these are secondary to purging. Now again, treatment, usually outpatient treatment. These patients are not very secretive, so we can treat on outpatient basis. Psychotherapy like CBT is generally the first line treatment, and also drugs like SSRI, fluoxetine has shown some good results. Now, next eating disorder is binge eating disorder. So it is a new entity and it is the most common eating disorder. Out of the 3, it is the most common eating disorder. Again, it is more common in females, but the ratio is not as vast in bulimia and anorexia. It is 1.7:1. Now, episodes of binge eating, as the name suggests, but there are no compensatory behavior. So there is a sense of lack of self-control. Only episodes of binge eating are occurring, not followed by any compensatory mechanism. So name is telling you binge eating disorder. Now, in here, the weight is usually the patient may be overweight or obese range, and many of the times complication is because of this. Now, treatment is again, CBT is the first line treatment. SSRIs may also be used. Now, there is one drug, lisdexamfetamine, which is approved by FDA for short-term treatment of binge eating disorder, to decrease weight, to decrease binge episodes. Long-term efficacy and long-term side effects is still not confirmed, but for short duration, this can be used. Now, so most common eating disorder overall is binge eating. Now earlier, bulimia nervosa used to be more common than anorexia, but now recent studies have shown that lifetime prevalence of anorexia nervosa is 2 to 4%, while for bulimia it is 2%. So you can say that anorexia nervosa is slightly more common than bulimia nervosa. Now let's come to the next disorder. This is personality disorders. So personality disorders, basically these are pattern of behaviors and inner experiences that deviate significantly from individuals' cultural standards. So these are some behavioral and inner experiences pattern which are abnormal or which are deviated from the normal pattern. So this is personality disorder, which leads to significant distress or impairment in functioning, since it's a disorder. Now, what is personality? Personality is a unique ways of adjusting to day-to-day situations. So all of us have a personality, but sometimes when these behaviors become abnormal or deviate from the normal standards, we call it as personality disorder. These personality disorder usually have an onset in adolescent or early adulthood. So personality also usually begins in this stage, during the adolescent, early adulthood, during this period of 17, 18, 19 years. Similarly, personality disorders would have an onset during this stage, and just like personality remains stable through time, these disorders will also remain stable and for a long duration. So in the history, you will get that these symptoms are occurring for a long duration. This is how a patient with personality disorders will present to us. Okay, some personality disorders such as antisocial, borderline, they tend to become less evident or remit with age. So maturing process or maturation may occur by 40 years, in which some of the symptoms may resolve, but many of the disorders, personality disorder, may continue even after that. So personality disorders are divided into 3 clusters, cluster A, B and C. So certain group characteristic of cluster A is they are odd eccentric, cluster B they are dramatic, impulsive, and cluster C they are anxious, fearful. Or you can remember cluster A, they appear weird, cluster B wild, and cluster C worried. This is how also you can remember. So let's talk about some important characteristic of each of these cluster. Cluster A, paranoid personality disorder. Please remember, the name is paranoid, but there are no delusions and hallucinations seen. If delusions and hallucinations are seen, it will be a psychotic disorder. So here there is long-standing suspiciousness. These patients have a lot of suspiciousness and distrust of others. So they are very suspicious, not up to a level of delusion. So they may, they may suspect without any basis, and they may think that others are exploiting or harming. They may try to read, hidden meanings, hidden threatening meanings in benign events. Somebody standing outside, they may, start to think, oh, so this person may, do something, false, something bad. So they have this tendency of not trusting easily. You go and, you come and help them, and they may say, this person is helping me, maybe he has some benefit of helping me. So they're always like this. And they may often bear grudges. Okay, you go and ask for help, they may say, oh, you're coming for help, you remember 2 years back on this Thursday what you did to me. So they often, try to hold on to grudges. This is paranoid personality disorder. Next is schizoid personality disorder. In schizoid personality disorder, these have long-standing pattern of social withdrawal. So they usually, live in isolation. They're emotionally cold, indifferent, you praise them, you criticize them, doesn't matter to them. And they may prefer solitary activities. They may not get involved in group activities, and they often lack close friends. So this is schizoid personality disorder. Then schizotypal personality disorder, they have social difficulties and they have very eccentric behavior, very odd behavior. They often, exhibit odd beliefs, magical thinking, like, they may believe a lot in superstition, like beliefs in, sixth sense, telepathy, a lot of these, beliefs they may have. Their speech again may be vague, very, very elaborative, reflecting odd thinking, very circumstantial, you may get bored listening to what they're saying. And often they may have illusions, ideas of reference. So not up to a level of delusion, but again, that maybe, somebody is talking about me. Such suspiciousness may be seen in these patients. Coming to cluster B, now usually the treatment again in all these personality disorders is therapy. So let's talk about cluster B. First is antisocial personality disorder, also known as dissocial personality disorder. So as the name suggests, they're antisocial. So they do not have regards for rights of others. They may start beating, fighting with anyone. So they don't regard or respect the rights of others, and they often violate them. Frequently involved in unlawful activities like theft, lying, conning. They may also show impulsivity, irritability, very aggressive behavior. They, get into physical fights a lot. So they are antisocial. Then they often, do not have any guilt or remorse for their action. They may even blame others. They harmed someone and what they may say, he deserved that. So, they don't, have that guilt or remorse of their action. And many times they may also be associated with substance use disorders. So a lot of, you see, 90s movies, villains, may be having antisocial personality. Next is very important, borderline personality disorders. So borderline personality disorder is more common in females, and it is characterized by symptoms like unstable interpersonal relationships. So on one day they may idealize you, oh, you're my best friend. On the other day they may say, you're the worst person I know. Please get out from my sight. So they have unstable interpersonal relations. They have identity disturbance, so they have unstable self-image. So there may sudden shift of goals, values, sexual identity may change suddenly. So they have problems in identity disturbances. Impulsivity again is seen. Again, potentially self-damaging activities they may indulge into. For example, a lot of spending, reckless driving, substance use, sexual activities. So impulsivity is often seen. Recurrent suicidal behavior, gestures or threats may be seen. So they may, have, recurrently they may, threat to, cut their, wrist latching may be there. If you see, there may be multiple intention marks may also be there. So this behavior is there. Mood is unstable. So they may be, out of nowhere, there may be anger outbursts you may see. They often report of feelings of chronic emptiness. So these are some of the symptoms of borderline personality disorder. These patients often always appear to be in a state of crisis. And sometimes short-lived psychotic episodes, micropsychotic episodes may be seen, but these are very, very transient, very fleeting. Okay, such episodes may occur in a state of crisis. Now coming to the treatment of borderline personality disorder, you should know this. Again, therapy is used, and one such therapy is dialectical behavior therapy, DBT. So DBT is one of the therapies which is used for treatment of borderline personality disorder. So in borderline personality disorder, they have a thinking of, black and white thinking, or, splitting is seen. So in dialectical behavior therapy, this is corrected. Then other therapies like mentalization based therapy and transference focused psychotherapy may also be used, but the therapy of choice will be DBT. Next is histrionic personality disorder. Now they show a high degree of attention seeking behavior. So, they would try to gain or seek attention. So their speech, emotions are very exaggerated. They may often, behave in a very colorful, dramatic and a very, very extroverted way. They want to be the center of attention. They may, use inappropriate sexual seductive behaviors. They may appear very flirtatious. They may use their physical appearance to draw attention. So this is histrionic personality disorder. Next is narcissistic personality disorder. Now they have a heightened sense of self-importance. They would, expect to be recognized as superior, although they may not be having that much achievement. They want to be, again they have that heightened sense of self-importance, that I am very important. Preoccupied with fantasies of power, success. They often, want people around them who are, always admiring them, who always buttering them. So they require that excessive admiration. They often are exploitative, and they may even lack empathy towards people around them. So this is narcissistic personality disorder. Last is cluster C. So cluster C first is avoidant anxious personality disorder. Here, as the name suggests, they are extremely sensitive to rejection. So they fear criticism, disapproval or rejection. So what, so they would not put their point of view in a fear that what if I am criticized or I am rejected. So they are avoidant or anxious personality. Now they view themselves as socially inept or inferior, although they may not be such, but they view themselves like this. Next is dependent personality disorders. As the name suggests, they have difficulty in making everyday decisions. So they're dependent on others for advice and assurance. So, what food should I eat? Let me call my mother and ask. What should I wear today? Let me ask my friend. So on day-to-day small decisions, they're dependent on others. They don't want to put responsibility on themselves. They want to put it on others. So this is dependent personality disorders. They need others to resume the responsibility, and difficulty in expressing disagreement, because of the fear, what if they lose their support? They're dependent on other, and what if they lose that support? And they lack confidence, and sometimes they cannot initiate new things. Lastly is obsessive compulsive personality disorder. In ICD-10, it is also known as anancastic personality disorder. Now please remember, the name is obsessive compulsive, but there are no obsessions or no compulsions. So what type of behavior is seen? They're preoccupied with details, rules, and organization. So give them a task and give them some steps, they will follow all the rules and regulations. Somebody tells them, look, it can be done in simpler way, they will say, no, I will follow all the rules. So they show perfectionism, that sometimes can interfere with the task completion, so much so that they might not even be able to start, because they are spending a lot of time to be, doing it in perfect manner. They show rigidity and stubbornness and often very inflexible. They are difficult to change the way they are doing the task. So this is obsessive compulsive personality disorders. Now ICD-11, basically it's in the older classification of the classification personality disorder is removed. In fact, in ICD-10, borderline personality disorder was termed as emotionally unstable personality disorder. So that classification in ICD-10 which was there, it has been removed in ICD-11. And ICD-11 classifies the personality disorder based on the severity as mild, moderate, and severe personality disorder. Now, then there are various types of personality. Type A personality, type B personality. What is type A personality? These are very competitive. They're very time urgent. Oh my God, I am losing my time. So they have this time urgency. They're very hostile. They're very, very ambitious and impatient. They're very, very competitive. And it is seen that in these patients, there is a twofold risk of myocardial infarction and coronary artery disease related mortality. So increased risk of cardiovascular disease in type A personality. While type B, they're easygoing, very relaxed. They're non-competitive. They focus more on enjoyment and than on winning. So they're very calm. So they don't have that increased risk of cardiovascular disease. Then there is again now newer type D personality. They have negative affectivity, that is tendency to experience negative emotions more, and social inhibition, tendency to not express emotions. So they have these features, and again they also have been seen to be predisposed to development of coronary heart disease. So even type D are predisposed. Now then let's talk about impulse control disorders. As the name suggests, there is an impulse is a feeling of increased tension and arousal that leads to a performance of a certain act. So these patients have difficulty in controlling impulses. So till the time they don't do that act, there is an increase in tension. So one is pyromania. So as the name suggests, recurrent purposeful setting of fire. So they have a recurrent impulse to set fire in absence of any clear motives. They don't have any monetary gain, or they are not setting fire because they want to take revenge. But this, impulse is there, that till the time they don't set fire, this impulse keeps on increasing. So there are recurrent episodes of setting fire. Then kleptomania. So kleptomania is basically recurrent stealing of objects. So they would, steal objects that are not needed for, any monetary value or any, personal use. But the act of stealing is important because there is a growing impulse to steal. So this is kleptomania. Now let's talk about some important topics of psychology. Now let's talk about a very important person, Sigmund Freud. So Sigmund Freud is the person who coined the term psychoanalysis. Psycho means mind and analysis. So analysis of the mind. So basically Freud said that our childhood memories, our unconscious mind, they play important role in our behavior as well as also a role in development of psychiatric disorders. So Sigmund Freud is also known as father of psychoanalysis. So he devised various techniques to analyze the mind. Now, there are certain important phenomena which may develop between a therapist and a patient, because, again, it's a very, very important relationship between the patient and the doctor, and the patient may share a lot of things which he may not share with other person. So first is transference. Transference is patient's feelings which may be conscious or unconscious. Conscious means the person is aware, unconscious means the person is not aware. So these are feelings of the patient towards the therapist, okay, that are based on past relationship with some significant figure. These can be positive feelings or negative feelings. For example, a 30-year-old female patient says to a 50-year-old therapist that you're a very mean person. You're just like my stepfather. Okay, very rude, very mean. So again, this is transference here. In this case, there is negative transference. Again, it may be based on some past relationship. And transference many times is used in therapy because it may tell us that there may be certain conflicts. Like in this case, there may be conflicts related with a stepfather. So transference is used in therapy. Second is counter transference. It is feelings of the therapist towards the patient. Again, they can be conscious or unconscious, and again, they can be both positive and negative. Now, Freud divided the mind into three parts in the topographical model of mind. So he gave certain theories of the mind. One was this, in which he divided the mind into conscious, pre-conscious and unconscious. Conscious is the mind where the content is in our awareness. Okay, so anything, which around, things occurring around which you have the knowledge, that is in the conscious mind. Then pre-conscious is that the content actually is not in your awareness, but it can be brought into your awareness by focused attention. Suppose if I ask you, on this very day, 1 year back, at this very moment, what were you doing? You'll say, sir, I don't know. But if we go back each day, maybe there may come a time when you are able to remember. So that is pre-conscious. Then unconscious is when the content are kept away from our conscious awareness. So many of the things may be in our unconscious mind, which we are not aware. Now, then Freud also tried to describe certain phenomena to know the content of the unconscious mind. One of the technique is free association. So what is free association? In which the patient is allowed to speak uninterrupted. So patient is told that, whatever is coming to your mind, just keep on saying without, censoring anything. So again, in this way, many of the thoughts which might be there in the unconscious mind may be reverted. So they may be known. So this is free association. So Freud would make the person lie down on the couch, would sit nearby, but he could not see the patient. The patient could not see him, and he would keep on telling the patient, just say whatever is coming to the mind, and he would keep on recording it. So this is free association. Then another method is slip of tongue, parapraxis. So Freud said that these are not simple mistakes. Sometimes things come out of our mouth and we just say this is slip of tongue. But Freud said this actually conveys some important information from the unconscious mind. So this is another method. Then Freud again gave another theory here, in which he said that the mind is divided into three parts in the structural theory of mind: id, ego and superego. Id is the instinctive drive. So it is the instinctive drive. It is based on pleasure principle. So id, part of the mind, wants immediate gratification. So it's like animal. So immediately if he wants to eat, it wants to eat. If it wants to sleep, it wants to sleep. So it lacks the capacity to delay urges. And it lies mostly it is totally in the unconscious mind. So this is id. He also tried to correlate these two. So he said id is in the unconscious mind. Then second is ego. Ego is the executive organ of the psyche, which works in reality principle. Basically, it balances between id and superego and the real world. It spans across the conscious, pre-conscious and the unconscious mind. So various defense mechanisms are used by ego to balance out anxiety. So these defense mechanisms are basically in the unconscious part of the ego. And lastly, it is superego. Superego is the moral compass which insists on socially acceptable behavior. It tells the person what to do, what should not be done. So follow the rules, do what society tells you to do. And it is not present at birth, but it develops at age 5 to 6 years. Again, it is mostly unconscious, but it also has parts in conscious and pre-conscious mind. Now, for example, a student is studying, the id is telling, let's go out and have a party. While superego is telling, no, you have an exam in coming days, you should study. So there is a fiction, one mind is saying do this, other mind is saying do the opposite. So now ego will come to the rescue. Ego may say, let's study for half a day, let's go and party in the rest half of the day. So this is ego is working on a reality principle. Now let's talk about some defense mechanisms. So these are basically tools which are used by ego to prevent development of excessive anxiety, which may occur, as we had discussed, because id and superego may go in different directions. So it tries to balance. So let us discuss some of these defenses. First is projection. So what is projection? Person projects his own desires to someone else. Okay. So for example, Mr. P, he is committing adultery, he is having an extramarital affair, but he is convinced that his wife is having an extramarital affair. So he is projecting his own inner feelings onto his wife. This is projection, which may be seen in schizosis. Then acting out. So as the name suggests, unconscious wishes are enacted in the behavior to avoid being aware of them. So person is acting out his unconscious wishes. For example, a student is angry on his friend, but rather than saying it, he just, throws a book at him. So this is acting out. Again, it can be seen in disorders like impulse control disorders. Next is regression. As the name suggests, regression, returning to the earlier stages of development to avoid anxiety of later stages. So person is regressing to the earlier stages. For example, to act childish or younger self. For example, a husband, returns home after a stressful day, a lot of anxiety, and starts talking in baby talk. So my Shona, Mona, with the wife. So this is regression. Next is inhibition, unconsciously limiting an aim, okay, and accepting partial fulfillment of desire. For example, person is not able to clear the exam for MBBS and person becomes a veterinary doctor instead. So there is partial fulfillment of desire. Next is intellectualization. As the name suggests, excessive use of intellect to escape painful emotions. So for example, a person is got diagnosed with a metastatic tumor. Rather than, again showing emotion, the person starts talking in great deal about, how the doctor reached the diagnosis, what stage it is, how it is reached, what stage, and what is the other, factors related with the tumor. So person is using intellect to escape the painful emotions. This is intellectualization. Isolation of affect, as the name suggests, separating emotions related to the stressful event, but reality is accepted. For example, man comes home and tells his family of his lung cancer without any emotion. So there is isolation of affect. Then displacement, again as the name suggests, there is unconscious shifting of impulse from one object to another to solve the conflict. So it usually percolates downwards. For example, a man is angry on the boss, he comes home and shouts on the wife. So it's displacing his anger from the boss to the wife. Now wife becomes angry and she shouts on the son. Now son punches his toys. So this is displacement. Undoing, as the name suggests, an act to nullify a previous act. So person does something to nullify a previous act. For example, a man is sexually provoked by a woman he sees, and to undo this, what he does, he leaves immediately and buys flower for his wife. Another example, many of people do touch wood. If some unwanted thought come to mind, they do this touch wood to undo that act. So this is undoing. Rationalization, again as the name suggests, giving logical explanation for unacceptable behavior. So some logical explanation patient tries to find out. So person says that he drinks alcohol because it kills all the germs in the body. So again, what kind of logic is that? So person tries to rationalize his unacceptable behavior. So again, it can be seen in disorders like substance use disorder. Reaction formation, unacceptable impulses are transformed in the opposite. So there's a reaction formation. So, boy is fascinated with, pornography. He organizes anti-pornography campaign. So the unacceptable impulse are now transformed into the opposite. This is reaction formation. Repression. So ideas or feeling are eliminated from the consciousness, which you cannot access. So the person forget, and then you forget that, that you have forgotten. So this is repression. For example, a child was abused by mother, now has no memory of the abuse. This is repression. Now, next is altruism. What is altruism? Constructive gratifying service or social service to others to deal with own, inner feelings. So altruism. For example, after the death of the husband due to smoking, the wife starts no smoking campaign, so much so that she is fully involved, and it may be detrimental to her own health, but she is totally involved in the campaign. So this is altruism. Next is suppression. Now all the other defense mechanisms are unconscious. That means it is done by the unconscious mind. Person is not aware, that he is using these defenses. It is just reflected in the behavior. But this suppression is a conscious defense mechanism. This is the only one which is conscious. So suppression is conscious decision to postpone attention to a conflict. For example, a student decides to forget about the coming exam and just takes a day's break and enjoy that day. So this is suppression. Lastly, humor. Using humor to deal with unpleasant situations. So for example, a man comes out, and laughs after getting scolded by the boss. So this is humor, use of comedy to deal with unpleasant situations. Now, defense mechanism you can remember in OCD by this mnemonic I2. So there is an upcoming movie Indian 2, I2. You're watching in 2D. In 2D, you're watching in the first row. So 2 I's are inhibition and isolation of affect. 2D, displacement and undoing. And R is reaction formation. So these are some of the defense mechanisms used in OCD. Now, Freud also, described stages of psychosexual development. So Freud said that all of us undergo these stages of sexual development, may not be just sexual gratification, but gratification through various other routes. So he proposed 5 stages of psychosexual development first. Okay. And he also proposed, in fact, that if the person get arrested at a particular stage, that means the person is not able to overcome one stage, that there may be fixation. And fixation in a particular stage may lead to development of certain disorders. The first stage which he described in this was oral stage. Oral stage is from birth to 18 months. Here the pleasure is derived through oral cavity or oral gratification. So by biting, chewing, sucking, the child derives pleasure. So anything he sees, he puts in the mouth. If there is fixation at this stage, the child may develop schizophrenia and substance dependence. Second is anal stage, which is from 1.5 to 3 years. Here the major site of gratification is anal, through excretion. And it is important, if fixation occurs, it may lead to development of obsessive compulsive disorder or OCD. Next is phallic stage, from 3 to 5 years. The site of pleasure is genital area. So the child tries to stimulate the genitals to get pleasure. Now some interesting phenomena described under this stage is, one is that the male child may develop what is known as Oedipus complex. So there is attraction towards the opposite parent. So in Oedipus complex, you can remember with the mnemonic mom, the male child having Oedipus complex is attracted towards the mother. So child has attraction, so male child has attraction towards the mother, also develops what is known as castration anxiety. So it is basically fear of castration by the father if he finds out when the child, attraction is there towards the mother. So this may also occur in this stage, and gradually the child is able to overcome this, after when the child passes through this stage. Now in female child, the child may develop what is known as Electra complex. So it is attraction towards the father. So female child may develop Electra complex, where there is attraction towards the father. Also in the female child, there may be seen penis envy. So penis envy is discontent with the female genital, genitalia, following a fantasy that it resulted from the loss of penis. So, according to Freud, so a female, craves for bearing a penis. So this is penis envy, which may be seen in female child during this stage. Next, again in the fixation here, the child may develop hysteria like dissociative disorders, conversion disorders, and even sexual deviations may occur. Next is latent stage, which is from 5 to 6 years to 11 to 13 years. So it is a latent stage. So relative sexual quiescence or inactivity is there. Oedipus Electra complex usually get resolved at the beginning of the stage. Superego is formed. We discussed by 5 to 6 years it starts to develop. It is formed, and mastery of various skills may occur during this stage. Lastly, there is genital stage. It occurs from 11 to 13 years up till young adulthood. So maturation of genital functioning, development of adult sexuality and adult identity may occur during this stage. Now let's talk about forensic psychiatry, some of the important aspects of forensic psychiatry. First is the Mental Health Care Act 2017, MHCA 2017. It's a new legislation that deals with treatment and rights of person with mental illness, and it came into being in 2017. Now, first is we should know what is capacity. So capacity is to make mental health care and treatment related decisions. So any person, we say he has the capacity to make such decisions if the person understands the information that is relevant to make the decision. So if he understands the information. Second is if he understands the consequences of his taking the decision or not taking that decision. And lastly, if he is able to communicate that decision. So if the person is able to do these things, then we say that he has the capacity to make mental health treatment related decisions for himself. Now, then there is another important concept, that is advance directive. So advance directive is that every person who is not a minor can make an advance directive in which he can mention the ways in which he wishes to be treated for a mental illness and the ways he wishes not to be treated for a mental illness. So basically, in advance, a person can write, the ways he wishes to be treated. Suppose currently he is not having any mental illness, but let us say in future he develops an illness. And at that time, if he loses the capacity to take decisions, so he can write and in advance, so from the name in advance, he can write a directive that how he wants to be treated and not to be treated if he's not able to make that decision at that time. Of course, if he has the capacity at that time, then it is, he can himself tell the decision. But if he does not have the capacity, then advance directive should be followed. Also, in advance directive, he can also mention the person he wants to appoint as his nominated representative. We'll discuss what is nominated representative. So advance directive would be applicable only if the person loses the capacity to take the decision. If he has the capacity, then he can tell himself. So nominated representative, what is it? Every person can appoint a nominated representative who, if the person loses the capacity to make treatment related decisions, then the nominated representative will help or will take the decision for the patient. Okay, and will help in the treatment of the person. So treatment related, mental health related decision will be taken by the nominated representative. Person can nominate a representative. From the name you can remember. Now, also some important points like admission of a person with mental illness. First type of admission is independent admission, when the patient himself wants to get admitted and he has the capacity to make that decision. So that those admissions are known as independent admissions. Then supported admissions, when a person who needs admission, like for example he's threatened or attempted self-harm for himself or to others, or he's unable to take care of himself leading to risk of harm. In those cases it appears that admission is required, but the person has lost the capacity to take mental health care or treatment related decisions and hence needs high level of support from the nominated representative who gives consent for admission in such cases. So those admissions are supported admissions. So under section 89, it deals with admission and treatment of person with mental illness with high supported needs up to 30 days. So initial maximum duration of admission is 30 days of supported admission. Of course, it can be extended. Okay, so various other sections, say like section 90, it can be extended beyond. But for the initial admission, maximum duration is 30 days. Now, there are certain procedures which are prohibited in the MHCA 2017, like ECT without using muscle relaxants and anesthesia. So there is a ban on direct ECT now. So earlier direct ECT would be given without anesthesia and muscle relaxant. Now it is banned. Now ECT for minors is also prohibited, but if the psychiatrist in charge considers that ECT is required, he should take the consent of the guardian as well as permission from the mental health review board. Then he can give ECT to the minor. Otherwise it is prohibited. Also restriction on psychosurgeries for person with mental illness. But again, if the psychiatrist in charge considers psychosurgery is required, it can be done after informed consent of the patient as well as approval from the mental health review board. Then they can do psychosurgeries. Now a very important addition is decriminalization of suicide. Now any person who attempts suicide, so earlier he was punishable under section 309 of the IPC, but now this act says that any person who attempts to commit suicide and he survives, it shall be presumed that he was under a lot of severe stress and shall not be tried and punished under section 309 of IPC. So again, it is decriminalization of suicide, which is an important addition in this act.